personal. It is political. It is collective. It is about us, Europe. With workforce shortages, fragile medicine supply chains, and rising healthcare costs, how can we secure our medical sovereignty? Across Europe, millions are living with rare diseases, unseen, hoping. But with medicine evolving faster than ever, in a continuing race against time, AI and biotechnology are transforming medicine. Where should we draw the line between innovation and integrity? Today, we are here gathered all driven by the same question. How can we protect what matters most? Welcome to the Euronews Health Summit. Shaping tomorrow's health. Today.
Well, a very good afternoon, everyone. A very warm welcome. It's a pleasure to see you all here today for the Euronews Health Summit. Well, it comes at a time when Europe's health landscape is essentially at a very it's evolving rapidly, of course. So this summit coming at a very pivotal point, from medicine shortages and supply chain pressures to breakthroughs in biotechnology and artificial intelligence, of course. The stakes for Europe's healthcare system have been rarely higher. So it's very, very important for you all to be part of this conversation today. And we thank you all for joining us, whether it's here in Brussels or online, our audience watching at home, on television or on digital. Thank you for joining us. Well, recent crises from, of course, the COVID-19 pandemic to shifting global dynamics have exposed vulnerabilities in Europe's healthcare systems. And at the same time, of course, Europe remains a global leader in pharmaceutical innovation. But as we know, global competition is heating up. From China, you see the headlines on Euronews, of course, as well, from Asia too. And over the past decade as well, Europe has lost a significant share of global pharmaceutical R&D investment, while the US and China continue to accelerate. So there's a central question here today that we're going to be covering. How can Europe strengthen its medical sovereignty, maintain global competitiveness, and also ensure resilient healthcare systems for citizens? Well, throughout this afternoon, we're going to be hearing from policymakers, we're going to be hearing from industry leaders as well, and we're going to explore the future of healthcare in Europe. But now, it is my pleasure to invite someone who's played an important role in shaping the future of Euronews to the stage. And just as well in a moment, I'm going to do that, but I would also just like to thank as well our partners, Sobi, for their support. We'll also be hearing from them later, so thank you very much. But please now join me in welcoming to the stage Chairman of Euronews, Pedro Vargas David. Thank you very much, Pedro.
Your Excellency, Olivér Várhelyi, dear Commissioner, dear Ministers, dear Secretaries of State, Ambassadors, members of the European Parliament, heads of units of the European Commission, ladies and gentlemen, dear friends. We do not pay enough attention to health affairs. Someday it's the Russian aggression against Ukraine, others it's the Middle East, sometimes it's the Mercosur, others, it's our farmers. Like in our own lives, we only think about health when it's either too late or too critical. And of course, COVID was the marking and the perfect example of this matter. Let me, with the privilege of setting the tone for today, leave you with some questions and reflections. I have nothing more than questions today, but I would like to share some of these questions from my side, and hopefully the discussion will take us there throughout the day. So for sure we're going to hear how can the EU support deeper research on these diseases that affect humanity. Namely, is the time, or has the time arrived for us to win the battle against cancer? How can we invest further in fundamental research for this purpose? And how can we protect private investment in the pharmaceutical sector? Billions of euros are invested by European companies every year, generating hundreds of thousands of EU jobs, and they are not always protected and accounted for. In fact, how do we balance properly the desire to have cheap drugs while protecting patents and investments? European investment. How can we cut on red tape to make these processes faster, while at the same time keeping them safe? And as a consumer, well, let me tell you my personal story of being a direct beneficiary of the wonders of Manjaro, with more than 20 kilos lost in the last year. Let us also discuss how we can enhance the prevention of mass diseases like obesity and diabetes. On the individual case, it is always a drama, but collectively, it's a huge impact on the budgets of European national health services. I said I had questions, but I also have maybe a question in the form of a suggestion. Should we not make the case for obese and diabetic compatriots across Europe to have free access to, and a second for advertising, Ozempic, Manjaro, or any other of the drugs, especially if they start being not injected but taken as a pill, to have this impact, courtesy of Brussels? If we pay for free Interrail to our young citizens, can't the EU make us all healthier and less obese? Well, I leave the reflection. Euronews is for sure the right platform for this discussion. Since our renewed arrival to Brussels, we are proud to have built the largest newsroom multi-platform covering the European Union. We are proudly European. We believe in this amazing, voluntary project of free and independent countries working together, full of imperfections and opportunities to improve, but always better together. And never forgetting that the legitimate critique to the office holders does not make us less Europeans or engaged with the project. We are also proud of our partnership with the European Commission, to which your presence, Mr. Commissioner, here is a testament, and I want to thank you personally for honoring us with your presence. With 19 languages across the continent covered by Euronews, no one informs Europeans as Euronews does. We are also proud of our partnership with our clients, corporates or states. Euronews worked with more than 200 clients in a transparent, ethical, and responsible way. And finally, we are proud of our journalists and our team. Let me have a special word today in this context. And I said that I believe there was too much Middle East in everyone's speeches. Unfortunately, now I have to speak about the Middle East. To speak about the more than 20 colleagues that we have currently that are working in the Middle East under day and night bombardment from Iran, and also our Farsi team, who very bravely continues to report about Iran and the world. The courage of these journalists in the front line, or those whose families are at risk, is a powerful reminder of our mission, one that is also done by our teams here in Brussels and around Europe. And every day, their work is an uphold of the values and the motto for which we exist: a neutral, responsible, and independent European news channel. And never forget, inside and outside, that there will always be haters and those that bark. But more people visit us digitally in one day than many others in the full year. I am thus very happy to open the second Euronews Health Summit here in Brussels, thanking all of you for your presence and hoping we can all benefit from today's discussion. Thank you very much.
Well, thank you very much indeed, Pedro Vargas David, the Euronews chairman there, for those reflections. Thank you very much. Well, indeed, health policy has become one of the most strategic priorities for the European Union, from strengthening pharmaceutical supply chains to advancing biotechnology and, of course, digital health innovation. Well, we're honoured now as well to welcome a policymaker who is at the centre of these efforts. So please, ladies and gentlemen, join me in welcoming to the stage Mr. Olivér Várhelyi, European Commissioner for Health and Animal Welfare. Thank you very much for joining us.
Ladies and gentlemen, good afternoon. It's a special privilege to be with you today and also to be on your screens through Euronews. And I want to thank Euronews for the initiative for the Health Summit, because I don't think since the COVID we devote as much attention to health as we should. Because health, I think, is still the biggest challenge in front of us for Europe, but also for the part of the world we are living in. So for me, this is a moment also to share with you what we have accomplished and what you should be expecting from us in the Commission in trying to meet these challenges. Let me start by a definition of what Europe stands for when it comes to health. The European healthcare model is unique in the world. It is unique, and we should preserve it, because it is not only a value, but it makes us different and makes us much more reliable for our societies than anywhere else in the world. Because this is a model where we have always access to the most state-of-the-art treatments. And this is the part of the world where this is available for everybody. Nowhere else you have such universal coverage of the state-of-the-art diagnostics and treatment. But I must also tell you that the signs are not very good. The signs are pointing that this model is under major challenge. We must face the reality, therefore, that the system is under pressure, and we just cannot take it for granted that it will stay with us tomorrow as well. Our population is aging and facing continuously growing burden of chronic diseases. There are less and less people financing our healthcare system, while we need to provide for more and more patients. Moreover, our healthcare system is facing a competitiveness challenge, both in the field of innovation capacities and safe supply of medicines and medical devices. So it was high time to come up with a new comprehensive set of measures, which we have presented back in December last year as a health package. Together with the pharma reform and the European health data space, it will put the European health industry at the forefront of global innovation race and will deliver for the citizens the best health technologies, including digital technologies, especially artificial intelligence. This is the only way to save the unique European healthcare model. Of course, biotechnology is a central piece of this package, as it holds the promise of transforming healthcare as we know it. So let's look at biotechnology first as the first pillar of our future European healthcare system. Today, the biotech sector contributes nearly 40 billion euros to the EU economy. And 80% of that comes from health biotechnology, which is growing twice the pace of the rest of the economy in Europe. So the potential is huge for our economy and competitiveness, but most importantly, for our healthcare system as well. Because it holds the promise for more precise diagnostics and completely new treatments, personalized to each unique need, and creates the opportunity to focus on prevention instead of providing care. To deliver this promise, we need to support our innovators and bring biotech products from the laboratory to the factory and on to the patients as fast as we can. This is the very purpose of the Biotech Act, as we have proposed it. This act will simplify the rules to cut down approval timelines for clinical trials without compromising safety, quality, or ethical standards. For a multi-country trial, authorization times should fall from 106 days currently to 75 days. And for single-country trials, from 75 days to 47 days. Just to put it into perspective, in the US, it takes 60 days. The Act will also support high-impact projects that contribute significantly to the EU innovation and biomanufacturing of advanced therapies, and will spur new solutions for areas where there are many unmet needs, especially oncology and cardiovascular diseases, the two biggest causes of death in Europe. To encourage investments, we are also boosting the financing environment in the European Union, including through an investment pilot together with the EIB group. This pilot links equity instruments with venture capital debt and will mobilize 10 billion euros into the sector over the next 2 years while waiting for the next MFF to kick in. Alongside the Biotech Act, we also proposed to simplify our rules for medical devices. From AI-powered testing and pacemakers and contact lenses, medical devices and in vitro diagnostics have grown into an essential piece of our healthcare systems. This sector is a major European asset. It employs nearly 1 million people. It includes more than 34,000 SMEs and represents a market value around 170 billion euros. However, the rules we have are creating unnecessary costs, bottlenecks, uncertainty for companies, and major delays for patients. This is why we have proposed simplification measures to make them more fit for purpose without undermining patient safety. The third part of the health package is the Safe Hearts Plan. Cardiovascular diseases are the leading cause of death in the European Union. We are losing 1.7 million lives every year, and it places a huge burden on the health systems, on our society, and on our economy. The Safe Hearts Plan gives us a policy tool at EU level for preventing, detecting, and managing these diseases, because 80% of these lives could be saved. 80% of these diseases are preventable. We will also act on unhealthy diets, therefore, and address the health effects attributed to ultra-processed food. And to give an answer to the chairman, well, Mounjaro is always just a medicine. It takes a personal commitment and effort to fight obesity and diabetes. And once you have diabetes, there is no way back. So the best is to prevent it. And Mounjaro might help you to do that, but it's not going to do it on its own. That is the reason why we are conducting this year studies and designing tools to help citizens to make informed choices about their own nutrition. Appropriate instruments, including financial ones, if needed, will support this reformulation. Last December, we also reached a political agreement on the pharmaceutical reform. It goes without saying that this sector is also a major contributor to the EU's economy. It represents almost 11% of the EU exports and 5% of the manufacturing sector's economic added value. But the rules governing this sector are already over 20 years old. Our reform provides a much-needed update, which should make it ready for the future. It is designed to transform our regulatory system so that it can fully support groundbreaking therapies, especially for patients who face unmet medical needs. It gives pharmaceutical companies strong incentives to invent and innovate, while carefully balancing these rewards with essential public health objectives and keeping these companies innovating, testing, and manufacturing in Europe. We are also embracing the digital transformation by integrating digital tools and making the shift to electronic product information. We're simplifying procedural aspects and structures even further, making the system more efficient and agile. The pharmaceutical reform will also promote more equitable access to innovative treatments in all EU countries. This means that patients will benefit from medical innovation regardless of where they live. It will also address some of the issues we see around medicine shortages, such as stronger obligations or companies to ensure security of supply. A recent report shows that pharmacies now spend around 12 hours a week managing shortages only, with essential therapies like antibiotics and oncology treatments being more and more affected by the shortage. The Clinical Medicines Act, another proposal we made last year, will complement the pharmaceutical reform and should reduce dependencies on individual suppliers of critical medicines. It will also further encourage investments in the pharmaceutical sector. It is important to finalize this act as soon as possible so that it can start delivering results for patients across the EU. I have all promises and high hopes from the Cyprus presidency that this is going to be a priority for them to deliver. Likewise, we need to ensure that innovation in healthcare translates into real access for patients across all EU countries. The EU Health Technology Assessment will largely contribute to this effort. This is a process that, for the first time, provides an evaluation how well a new health technology performs compared to existing alternatives and how cost-effective it is. By strengthening cooperation at the European level, the health technology assessment can help reduce duplication of work across the member states and improve the overall scientific quality of the assessments. And we are also hoping this will speed up the availability of these products for the patients. Trustworthy data is also essential to make these assessments reliable. This is where the European health data space will play its role, and we are currently working hard on its implementation. The European health data space is one of the ambitious initiatives of EU health policy. European citizens will be able to access their health data in seconds, whether they are at home or in another EU country. This will transform how people access care and how health systems work together and how innovation reaches the patients. It will make health professionals' lives easier as well, as it means less paperwork, less manual typing, and more time to dedicate to the patient. Alongside this, the rules for secondary use of health data will help drive research and innovation, from new medicines discovery to the development of scalable AI in the healthcare. Because data is the next raw material of the new healthcare system in Europe. But of course, data protection must come first, and a strong confidentiality framework will guarantee that the data is safe and that the people stay in control of how it is used. So, ladies and gentlemen, we're living in uncertain times. By simplifying what should be simplified, implementing and enforcing and updating our rules, we move further towards the future we want. A future where innovation thrives and ideas are turned into treatments much faster, where preventing disease is the norm, and where Europeans can expect only the best from their healthcare system. If I may conclude with one quote, maybe, from Lampedusa, the Gottopardo, if you want to keep everything unchanged, you have to change everything. Thank you very much for your attention.
Well, Commissioner, thank you very, very much for sharing your insights and the plans, of course, of the Commission. Thank you very much. Well, now we will next hear a video, ladies and gentlemen, from Dr. Tedros Adhanom Ghebreyesus, the Director General of the World Health Organization. Thank you very much.
Commissioner Olivér Várhelyi, distinguished guests, dear colleagues and friends. Since WHO was created almost 78 years ago, the world has made remarkable advances in health. Globally, life expectancy has increased from 45 to more than 73 years. Smallpox has been eradicated, polio is on the brink, maternal and child mortality have dropped dramatically, as have deaths from HIV, malaria, TB, and more. But we continue to face many challenges: conflict, displacement, poverty and inequality, non-communicable diseases and mental health conditions, antimicrobial resistance, climate change, and epidemics and pandemics. None of these dangers can be managed in isolation. Shared threats demand a shared response. That's why WHO was created in the first place, and that's why countries continue to work under its umbrella. Just last year, they adopted the WHO Pandemic Agreement, a landmark instrument of international law to help keep the world safer from future pandemics. They are now negotiating an annex to the Pandemic Agreement, the Pathogen Access and Benefit Sharing System, or PABS, to ensure rapid detection and sharing of pathogens with pandemic potential and equitable and timely access to vaccines, therapeutics, and diagnostics. We hope those negotiations will be completed in time for this year's World Health Assembly so the pandemic agreement can be finalized, open for signature, and enter into force. As you know, WHO has been through a difficult process of prioritization and realignment following the withdrawal of the United States. We have now almost completed that process. We have reached a point of stability, and we're moving forward as an organization that's leaner, more effective, and more efficient. We're supporting countries around the world to address the many challenges they face, to harness the power of AI and digital technologies for health, and to transition away from aid dependency towards sustainable self-reliance based on domestic resources. Team Europe has been a strong supporter of WHO and the pandemic agreement. It's also helping to build stronger, more resilient health systems in more than 125 countries through the Universal Health Coverage Partnership. We look forward to our continued partnership as we work together to realize WHO's founding vision, the highest attainable standard of health, not as a luxury for some, but a right for all. I thank you.
Well, ladies and gentlemen, we now turn to a pressing strategic question. And this is a question facing Europe today. How can Europe secure its medical sovereignty? Well, the pandemic, as we've heard, has exposed vulnerabilities in supply chains, of course, in production capacity, and, of course, access to critical medicines and medical technologies. Well, since then, the EU has launched new initiatives, and we've just heard as well from the Commissioner the plans to implement new initiatives as well and reforms, and, of course, including pharmaceutical reform. The major questions remain about resilience, about innovation, competitiveness, and patient access. So to discuss this now, I'm delighted to welcome to the stage our panel for this debate, this discussion. Please welcome to the stage Olivér Várhelyi, the CEO of MedTech Europe. Please give him a round of applause. Thank you very much, Olivér. It's a pleasure to see you. Please take a seat. We also have with us Olivier Girard, Head of Unit for Medical Countermeasures at the European Commission's Health Emergency Preparedness and Response Authority, HERA. Thank you very much, Olivier. Pleasure to have you with us. And please as well welcome to the stage Adrian van der Hoven, Director General Medicines for Europe. Adrian, thank you for joining us. You have water, should you want to take a sip throughout this discussion, because you've got a lot to talk about, gentlemen. We do. So first of all, though, I would like to start with discussing what medical sovereignty means, because there's different perspectives on it. And the term medical sovereignty is used frequently in Brussels, as we know, but it can mean different things, as I said, depending on the perspective. So, Adrian, I would like to start with you. Your members produce a large share of Europe's essential medicines, and from the perspective of medicines production, what does medical sovereignty mean for Europe today, from your perspective?
Well, I think Europe remains a large producer of essential and critical medicines. Our members supply about 9 out of 10 of the critical medicines on the EU list. You have in pharmaceutical production the upstream, which is the chemicals and the active ingredients that are in there, and then you have the medicine itself, which is produced. Europe, we still have significant production of both the medicines and the active ingredients, but what we've seen is that over time, the growth of the production has mainly been in Asia, in India and China. So we are losing, if you wish, our competitive edge in terms of manufacturing. What we could do to strengthen the sovereignty is to encourage our companies to invest more in Europe, to strengthen our supply chains in case there are external events like wars in the Middle East or these kind of things that can disrupt supplies from outside. But also to have a more responsive industry. So if we have health crises like COVID-19 or wars, you will have a surge in demand, and you need to have an industry that's quick and responsive. So this is, for me, what health sovereignty would mean. Okay,
thank you very much, Adrian. Olivier, from the Commission's perspective, what does medical sovereignty actually mean in practical terms for Europe's health security?
So for us, it's a concept which is directly drawing from the experience of COVID-19. And we have decided that it should be something on which we should develop tools, instruments at EU level to ensure this sovereignty. When it comes to experiencing medical sovereignty in times of crisis, I think there is an image which is quite simple, which is when you go to the pharmacist. When you go to the pharmacist, you need to make sure that the medicine that you have been prescribed is available, that you have the right medicine, and of course that it is in stock. So those are the two priorities that the Commission has been working on, in particular since the foundation of DG HERA, since the extended mandate of the EMA, and of course through the massive legislative reform which is currently in place. And simply when it comes to sovereignty, indeed there is the element of access. So all our priorities when it comes to developing partnership with industry for the supply of medicine relies on security of supply. Security of supply is paramount. This is clearly a challenge that is coming up on a regular basis and of course including at this very moment. So this is why we take great care when we develop partnership with industry to make sure that we have suppliers coming from different angles. We have contracts for vaccines with several suppliers when it comes to pandemic flu, for instance, or COVID-19. And the other element that we want to make sure is to make sure that we have access to the right medicine. And the right medicines means the medicine that will help fight the threat that is going to happen. And in this context, innovation is very important. This is why we finance innovation. We want to have an ecosystem which is operational and which is supporting the development of new actors, new players, because we want more competition, we want diversity, and of course, we want cutting-edge innovation to be able to be prepared for the next crisis. So for me, sovereignty for medicinal product is very operational, is very concrete. It means access, and it means innovation.
Excellent. Thank you very much. And Oliver, the conversation often focuses on pharmaceuticals, but medical technology is just as critical. And we heard as well from Commissioner Várhelyi how they're going to improve regulations and simplify the medical devices, the reforms around that. I'm sure you're very happy to hear that as well. But medical technology, therefore, just as critical. But what does medical sovereignty mean in the medtech sector, especially given global supply chains?
Thank you for the question. The truth is I've not yet found a harmonized EU definition of sovereignty, but some very good keywords have...
Not even with ChatGPT?
Well, I don't use ChatGPT. Perhaps I should not admit these days. But I think Olivier put it well. A lot of this is about ensuring security of supply of the things we need. Now, behind that very simple phrase, a lot of people put different things into it, right? There's the manufacturing piece, which Adrian started with, and a number of the public sector actors we engage with believe security of supply is best ensured by making more health products here. Let's not be as dependent on foreign imports as we were during the pandemic and the aftershocks which followed. But quite frankly, that's only one route to having security of supply. We cannot make everything here in Europe, and the medtech sector, which we represent, is a fantastic example of this, because what is medtech? It's all health products which are not pharmaceuticals. That means whether they're diagnostics, treatment devices, monitoring devices, injectables, they can be made out of effectively anything. Anything. Metals, electronics, plastics, advanced materials. Unless Europe can actually source everything domestically, Europe cannot make everything domestically. And that's why having true security of supply and therefore sovereignty means complementing a robust manufacturing base with other ways of accessing the materials we need to make medical technologies. So for me, sovereignty is actually about diversification of sources for our healthcare products, not replacing imports with domestic manufacturing, but not choosing imports over domestic manufacturing. It's about getting the most out of both of them so that when there are crises or where there are needs, we have a variety of places to turn to for the technologies we need.
Indeed, and as you said, one of the biggest lessons from COVID-19 was Europe's dependence on those global supply chains, particularly for active pharmaceutical ingredients and key medical components. So, Adrian, this question then goes to you next, please. Many essential medicines, of course, rely on production outside as Europe, as you've highlighted. How risky is that dependency today?
Well, obviously, in today's volatile geopolitical environment, the risks are unfortunately higher than they were, I would say, pre-COVID times. So we need to think about having diversity, but also investing here in Europe. We still produce about 45% of our API in Europe and about 30% of the generic API in the European Union. So we still have a robust active pharmaceutical ingredients sector in Europe. But I would say it's challenging to invest in Europe in this space. It's very cutthroat in terms of price competition, primarily with China and India. And so it's difficult to maintain this. There are reforms underway now, Critical Medicines Act, Pharmaceutical Legislation, Biotech Act, which aim to reorganize a little bit the market for medicines in Europe to make security of supply one of the components along with lowest price, because today the policy is lowest price. But it's a work in progress, I would say, because the European Union needs to massage and work the member states into this position, because essentially they are the buyers. So if they don't want to spend 5 cents more, and that's what we're talking about sometimes, 5 cents more for a medicine, they won't spend 5 cents more, even if it means more robust security of supply. And I think that's a big challenge, but I have to say the European Union is putting a lot of legislation into place to change this focus.
A big challenge, and yes, indeed, a lot of new rules coming into force to help change that. But Olivier, from HERA's perspective, obviously HERA was created after the pandemic to strengthen Europe's preparedness for health emergencies. What concrete tools does HERA now have to ensure the security of supply of critical medical countermeasures during a crisis?
No, thanks for asking. I think what was interesting from what Adrian said is that indeed, I would say when it comes to security of supply, the core debate is at the level of the member states because they are the buyers. However, when it comes to HERA, we are the buyer. EU is the buyer, either with the help of the EU budget or by bringing together all the member states, all the countries which are interested. And so for this purpose, we have a variety of instruments that have been developed since the crisis to ensure indeed that we have the sovereignty when the crisis comes. So maybe.
And is there a will?
Yeah.
A will to spend an extra 5 cents, as Adrian pointed out?
I think as far as we are concerned, this is definitely our priority. Security of supply means indeed being ready to pay more. But of course, if you look at the cost of COVID-19, 6% of our GDP was wiped out during the first month of the crisis. The price to pay is very small. And when we act and when we build those partnerships with the medical devices industry, with the generics industry, I mean, we do it in different ways. We have stocks. So we have 1.2 billion euros of stocks, which are ready to be mobilized in times of crisis. We have contractual arrangements, and that happens through pool procurement. I think maybe possibly with Latin America, we are the Latin America organization. We are in the leading position globally for pool procurement because we have 38 countries supporting us in this effort, buying medical countermeasures to be ready for crisis. So we have developed a varied portfolio of medical countermeasures, and we are ready to do more. We have also decided to reserve manufacturing capacity in Europe, because obviously during the crisis that was absolutely essential for the production of vaccines. So we do have platforms that we have reserved in various countries in Europe to be able to host various types of vaccines, because it's a question of technology, of course, and we are looking to expand this model, which is called EU FAB, towards new areas like medical devices, like personal protective equipment, because it means that we are both making sure that we have the medical countermeasures available in times of crisis, but at the same time that the company has visibility and has a regular flow of order, because as Adrian was saying, you need a market, and you need to be able to create a market also in peacetime to be ready in crisis time. And then finally, what we want also is to avoid the situation of the COVID-19 crisis, where when confronted with this threat of completely unprecedented characteristics, we had to rely on networks of contacts. We had to rely on the phone book to reach out to the industry or the professional association. There was no network in place. So this is what we want to do. That's what we are doing right now with the support of the professional association, to have those networks in place. It's an initiative called Ramp Up that we are developing right now to make sure that we have the industry with us to be able to be mobilized immediately when a crisis strikes. So we have to be innovative when it comes to our instruments. We realize that this is still early days, and this is also subject to financing at EU level, but we are confident that those are the right tools and that they can expand considerably, so that indeed we are much better prepared than we were 6 years ago.
Thank you very much, Olivier. And if I may move to you Now, Oliver, medical devices also face supply disruptions during the pandemic, as we've noted. But where do you see the biggest vulnerabilities in Europe's medtech supply chain now?
Well, once again, I find myself agreeing with a lot of what was just said. And DG HERA, by the way, I have to say, is a very needed and pragmatic organization that really ramped up since the pandemic. It's very hard to know, as Olivier's team can vouch for, what the next crisis will be and how it will compare to the last crisis. The medical technologies, the pharmaceuticals, and the wider medical countermeasures that were necessary for a crisis like COVID-19, which was an infectious disease pandemic characterized by lockdowns, etc., are not necessarily the medical countermeasures we'll need next time, which could be another pure disease pandemic. It could be a military or defense-related one as well. And I was always impressed to see the sheer range of scenarios that DG HERA forecast for. But some examples which were relevant for our sector during the pandemic and the aftermath, very diverse. I mean, you can consider a very simple medical device like surgical gloves, needed in the ICU, needed for medical procedures, even needed for basic hygiene during an infectious disease pandemic. Most of them, if not all of them, rely on a substance called natural rubber latex, which is sourced overwhelmingly from Southeast Asia. So again, it's a very good example of what I was saying earlier, that unless Europe can become suddenly a self-sustainable source of natural rubber latex, we will, for the foreseeable future, depend on other regions for something as simple as a surgical glove. On the other end of the spectrum, we have very, very advanced diagnostics, both lab diagnostics and imaging diagnostics, which can do amazing things when partnered with AI and give physicians the information they need about the condition a patient has. Well, guess what? Most of them are relying these days on components made with the famous rare earth minerals upon which Europe and many other regions depend on others to supply. So there are a diverse range of material and product dependencies to manage here. But as Olivier alluded to, it's not just the physical stuff you need. There is an important conversation to be had and started during COVID around manufacturing capacity. How can it be found? How can it be ramped up? I remember receiving phone calls during the pandemic from certain individuals in government saying, we believe we've found a car factory in a region of Italy that has a free manufacturing line. Can you use it to make ventilators? Because before the vaccines, there was a massive undersupply of ventilators. This was the kind of things we were doing ad hoc, finding manufacturing lines which can be adapted, finding the talent that can run them, which is particularly important if they are locked down, or if they're in an area like data science or AI, where everyone's scrambling to get them. And then just making sure that these manufacturing facilities are actually sustainable into the long term. So you've got the initial conversation around permitting and approvals, but then keeping them financially sustainable in the long term. All of this is actually vulnerabilities or dependencies that need to be managed alongside the material dependencies. But I don't want to make it all sound negative. What I'm saying is there's a very holistic set of things to look at here, and Europe is more serious than ever before in its ambitions and its efforts to try and become sustainable in this space. So that's to be applauded. It just requires the public and private sectors to sit down and have a real conversation about what works and what doesn't.
Thank you very much, Oliver. Now, as you said there as well, the surgical gloves, materials in Asia, we hear frequently, of course, from industry is that Europe is, as Adrian said as well, losing investment to the US and Asia. I just want to move on to competitiveness versus regulation as well. We've started talking about that. Let's continue. Oliver, medtech companies, often say that Europe is becoming less attractive for innovation. Why is that happening? You said their talent. Is regulation an issue as well?
Yes, thank you. I mean, this is a very important topic. Regulation is definitely a huge piece of this. In the last 10 years or so, Europe has actually gone from being the global epicenter of medtech innovation to being slipping, let's put it this way, in the world. It's due to a number of things. It's due to the business and regulatory environment here in Europe getting more complicated. It's also due to other regions of the world making successful efforts to become more competitive than they were before. And in the regulatory space, I mean, Commissioner Várhelyi just mentioned that the health package published on 16 of December included alongside the Biotech Act and other measures a reform of the medical devices legislation. This is a very needed and overdue thing, which we welcome very much. It's currently with the two co-legislators in Parliament and Council. It is a really once-in-a-decade opportunity for Europe to claw back some of its global competitiveness. Why? Because the ability to actually bring a technology, wherever it's manufactured, lawfully to market is such a critical piece of any health products manufacturer's global strategy. If it is inherently easier, whether that's cheaper, quicker, more predictable, to bring an innovation to market in one part of the world versus another, the technology almost inevitably flows to that part of the world where things are easier. That doesn't mean that we need to have the lowest standards in the world. We actually need the highest standards of the world for safety and evidence and all of these things. But the regulation must be smart, it must be predictable, it must be understandable, and it must be dependable for investors. What we've seen over the last 10 years, as the regulatory pathway went from being highly competitive to less competitive, there's a deprioritization of Europe on the global stage by many players in the medtech sector. If this is not addressed, the consequence is a gradual decrease in the R&D investment, because R&D tends to follow the market. And if that's not addressed, manufacturing follows R&D. So funnily enough, there is a link between these topics that we started off, which is manufacturing and the regulatory pathway. If we can claw back some global competitiveness for this industry in the regulatory space, it will actually have indirect advantages for the R&D spend and then for the manufacturing outlook too.
Thank you. And Adrian, you said as well, the pricing and procurement systems are undermining supply security. What are the main regulations for you that's holding back innovation and competition?
Yeah, so actually in Europe, the underlying demand for medicine is growing. This is because most medicine consumption is linked to an aging population. So as people get older, inevitably they will start taking more and more medicine. And so because of our demographics, we actually have a growing market. The challenge that we face is that healthcare systems, basically since the 2009 financial crisis, they have introduced cost containment policies, which was necessary, of course. In 2009, there was a massive financial crisis. Half of Europe was bankrupt. So this was necessary. But all of these cost containment measures, including price freezes from 2009, continue to apply today for medicine. So the price of bread has gone up by 45% over the last 10 years. The price of generic medicines has gone down by 8%. So it gives you an indication of, a disconnect between market forces, inflation, and a regulated market. So I think that's the main challenge. There are some positives. The Commission has introduced a Critical Medicines Act, the Biotech Act, which aims to boost competitiveness and manufacturing investments. And I think this can work. I think this definitely can boost. We have a challenge, I would say, sometimes with some disconnect, I would say, within the EU. So we have a lot of environmental regulation, and we're not against environmental regulation. Almost all of our companies are investing in decarbonization in a very big way. We're producing chemicals and use a lot of energy, so that's not easy to do. But most of our companies are really, really heavily investing in this decarbonization role. But we see a lot of other regulations, wastewater regulations, chemical regulations, all kinds of things that really are challenging to implement, and in some cases literally force us to move the production outside of Europe. And we don't understand this right hand, left hand, not talking to each other kind of thing. So we'd like to see that improved going forward. I think really we have an opportunity in Europe to boost investment in medicines R&D and production. This is very high capital intensive, high skill, high R&D industry, including on the generic side. We can, if we work together, compete with Asia. We just need to put the music together and make it play well.
Thank you very much, Olivier. Ensuring security of supply in a crisis is obviously, and balancing the costs is a challenge. How does the EU approach this challenge when it comes to ensuring access to key medical countermeasures during health emergencies?
I think that there is a recognition that security of supply has a price, and if you want to be ready for times of crisis, you need to pay a premium. It is a life insurance that you need to subscribe, and it doesn't mean, of course, that you will need to cover all supply of medicine, but you will need to make sure that you have some safe suppliers out there that you know, that you can trust, and that fulfill all the conditions to ensure the security of supply. So this has a price. But at the same time, I think that, if we use certain instruments, proactive instruments, we can mitigate the cost. When it comes to procurement, having reliance on a broad range of companies, a broad range of competitors can help us bring the price down. And this is what we're trying to do. We're trying to bring more companies into the market. We're very happy, for instance, that a small startup company active in the field of biological warfare was supported by the Commission from the outset, and now has a marketing authorization for ricin antidote, which is a very important tool in biological warfare. So that's a very good example, and we want to stimulate this ecosystem. The ecosystem of the medical countermeasures, medical devices, medicinal products, is very strong in Europe and needs to stay like this, but there are areas where we have been reliant on other places in the world, and this is why it's so important that we stimulate the ecosystem here in Europe. But at the same time, we know that when it comes to innovation, we will need at some point to rely on third countries. So this is why also we are very keen on developing security, health security agreements with third countries. We have strong relationship with countries like Japan, with countries like Canada, and we believe this is extremely important because we are looking for the same outcomes, we're looking for the same result. Let's remember that Japan, at the time of the COVID-19, relied on Europe for the supply up to 100 million vaccines, mRNA vaccine. And we were, of course, very happy to show solidarity. And let's imagine that, should a new crisis come, we might have to rely on Japan. So it's extremely important that we maintain this community focused on innovation, focused on security of supply. The industry basis in Europe is fundamental, and there are areas where we will need to make sure that there is manufacturing capacity. This is what we do for vaccines, because obviously when you mobilize manufacturing capacity, it is very important that it is close to where the needs are. But when it comes to innovation, when it comes to partnership, you need, as we are in a very innovative area, that you need to rely on the best brains and on strong institutional cooperation with third countries. So I think on this basis, we can, of course, guarantee the supply. This will have a cost, but we can mitigate the cost.
Oliver, you wanted to add something?
Yes, just listening to you speak, Olivier, I'm reminded that all this important conversation around partnerships with third countries, yes, it is about the health security partnerships, but it's also about the wider trade relations. I think one reason we discuss sovereignty, not just in healthcare, but many sectors right now, is not just because of the pandemic, let's face it. It's because of this oft-reported on breakdown of the international rules-based trading order, and more regions around the world abandoning free trade and WTO rules to pursue outright protectionism. Let's face it. I mean, our sector has encountered this for a number of years already, whether it's in China, Brazil, Russia, Saudi Arabia, United States now. President Trump has been very open that his tariffs policy was actually about you pulling levers so that pharmaceutical and other companies would build more factories in the US. And there are voices in Europe, including in some large member states, to jump on that international protectionist bandwagon. And that's where I think some of the calls for more domestic manufacturing come from. But if we actually do have globalized supply chains in sectors like medtech and others, we're going to need to be able to access the things we need from other parts of the world. So continuing to have workable trading relations, ideally open and rules-based ones, for us is very, very critical. If Europe or any other region of the world wants to jump on the protectionist bandwagon, which is so popular right now, you can do it, but that's also a bit of a race to the bottom. And it's going to end prettier for those regions of the world who have the most attractive markets. Europe has a market which is both attractive but also incredibly challenging at the same time. So I think it's a risky approach to just pursue that. We would much prefer a partnership model where other key third countries can rely on Europe and Europe can rely on them for us to mutually exchange the things we need. But that's a political question which needs to be answered very soon.
A big question indeed. Crisis, preparedness and future threats. I'd like to move on to that. And as you said, given the current backdrop, the trade volatility at the moment as well, let me ask this very important question, Olivier. You said we might have to rely on Japan. Is that going to be the case, do you think? Is Europe better prepared today than it was in 2020 if a new health emergency emerged tomorrow?
I think it's a very fair question, but I think as Oliver has mentioned, I think the lesson from COVID-19 is that protectionism doesn't work. And even if we were in Europe, even if we were in a single market, we know that there was a period of time where there were very strong protectionist temptations within Europe. And luckily, there was awareness and people realized that this was not the way forward. So I think that COVID-19 is there to teach us that protectionism is not working inside Europe, and thanks of course, to the fact that we have now a legal framework, that we have rules, that we have bodies, coordination bodies, which bring everybody around the table. And interestingly, as you just mentioned, the fact that we are also ready to extend this cooperation and this solidarity to reliable partners who want to work with us. And I think that's also what we want to appear. We want to appear as reliable partners. We have those instruments that I just mentioned, those innovative instruments, which means that we are better prepared with stocks, with capacity, with contracts, supply contracts, and networks of industry players and also other players, research players, academic players, and so on. So I think that's also a very, very positive situation. But there is clearly the fact that we need to continue ensuring a sustainable financing of this model. We have been innovative, we have been reactive, we have learned the lessons, but what we need to make sure is that we continue to have the means to finance this new way of doing things. And as I said, I believe that compared to the cost of COVID-19 and the price that we have to pay when it comes to health security threats, the price that we have put on the table so far is very reasonable, and we need to make sure that this is continuing to be the case with the new financial perspective. So we need adequate financing. That would be my message.
Thank you very much. We're running out of time, so I'd like to end with a question to you, Adrian, in one sentence, if you can. What is the single most important step you think Europe must take in the next 5 years to secure its medical sovereignty?
Well, I think it needs to create an investment framework through which companies will want to invest in my sector, but also the medical device sector. I'm also in favor of free trade and free trade agreements, but the reality is that we are also competing with these other regions. And if we want to keep a strong manufacturing sector, a strong R&D sector in Europe, we need to get that investment also in Europe. And if we lose that to other regions, we will struggle, because for any crisis we can have stockpiles. I know you have those reserves, and that's important. But when we have a crisis, the demand for medicines and for ventilators, I remember I worked with you guys during COVID, it went up between 300 and 1,000% overnight. It is so hard to adapt your production to this kind of surge, okay? It's like a crazy time. It can be done, but you need to have an industry able to invest, more digitalized, more investment in technology in the production site to be able to achieve this. And this needs investment. So we need to create a framework. Most of the investment will come from the private sector, but it has to be encouraged by the policymakers, the EU and the member states. And I think we still have a little bit of work to get this right.
Okay, well, gentlemen, thank you very much. That's all we've got time for today. Fascinating insights there. So thank you very much for joining us on this panel discussion. Please do take a seat and get comfortable for the rest of the show. Thank you very much.
Thank you. Thank you.
Well, we're just going to do some furniture rearranging as we get set up for the next segment of the programme, which is going to be a live version of The Big Question, which is a flagship Euronews show where we sit down with people in industry and talk about some of the most topical things on today's agenda. And of course, as you know, the health industry and artificial intelligence all merged together is certainly no exception. And as we've heard, it's clear that Europe's medical sovereignty will require stronger supply chains, smarter policy, and close cooperation between industry and institutions to get things moving. Well, now I think we are ready to go. Yes, we are. So I would like to say thank you very much all for joining us today. And as this is a live edition of The Big Question, I would just like to say thank you to our audience as well for tuning in to this episode of the show. And with that, I would like to welcome our guest for The Big Question, the CEO of Health AI, Ricardo Baptista. Later, please come to the stage. Ricardo, pleasure to meet you.
Likewise, thank you.
Please take a seat. Okay, well, Ricardo, we've had lots of insight there that we've just heard across the board, but we're going to talk about something as well that's been touched on. But AI, of course, promises to transform healthcare. And I'd like to talk to you about how we will actually see that transformation in Europe over the next few years. Are you able to share your insights with us on that to start with?
Well, thanks for having me, Angela. And it's such an exciting time when we talk about the intelligence revolution and how AI-delivered technologies will transform many sectors, and health will certainly be one of those. We at Health AI, we are the global agency for responsible AI in health, a global nonprofit based out of Geneva working with governments to build ecosystems so that we can scale AI technologies so that they can perform better health outcomes for citizens wherever they may be. That being said, going straight to your question, will AI transform healthcare? My answer to you is yes. The question is, will it do it for the better or for the worse? And what I mean by that is that if we just start to introduce artificial intelligence into our current models of care, into our current health systems here in Europe, we have a huge risk of actually accelerating systems that are completely broken. Because our health systems are fully focused on reacting to when people get sick. They are disease-reactive systems. And so we need to fix the system so that it focuses on prevention, on promotion of health, and on quality of life. So if you retrofit AI into our current models of care, you have a risk of becoming very efficient at being inefficient. And so the opportunity is here to use this intelligence revolution, but to transform healthcare completely so we can lower the burden of disease, as we heard at the beginning of today's summit, so that we can make sure that the citizens across Europe and the world can have better health outcomes in the future.
And to get those better health outcomes in the future, but what are the biggest problems in healthcare that AI could realistically help solve at the moment?
Well, AI is already here. Sometimes we talk about AI as something of the future. It's already transforming. Even during COVID, that we just heard about the pandemic, the development of new vaccines, almost every company was using some forms of AI. We're seeing AI across, so research and development, diagnostics, imaging technology, every field of imaging right now is using some form of AI. When we think about the treatments, robotics and surgeries, when we think about virtual assistants, virtual scribes supporting doctors in clinical decision making, even when we talk about the non-clinical aspects of healthcare in terms of fraud detection, financial claims with insurances, all of these fields have the potential of improving in terms of outcomes, be it in terms of cost saving, but also in terms of efficiency, in terms of improving health outcomes.
of course, the healthcare systems are under enormous financial pressure at the moment, of course, and historically they always are, but financially and operationally, can AI realistically reduce costs while also improving outcomes for patients? Sometimes one has to give.
Well, let me put it another way. If we don't do anything, our health systems are going to collapse. They are not sustainable. People are just getting sicker and sicker. We're seeing a population that is getting older and with multiple morbidity. And so if we do not change the system completely, and the Commissioner for Health mentioned this, putting prevention at the core of his strategy, we will not be able to have the resources to make sure everyone will have access to the health they need. Mind you, no Minister of Health, no Prime Minister or President in the world will ever say they're going to shut down the health system because it went bankrupt. What bankruptcy translates in healthcare is into longer waiting lists. So people who do not have money in their pocket or are in more vulnerable situations are the ones that are going to be left behind. And so if we are serious about making sure that universal health coverage is a reality, that people will have access to the health they need and to the care they need when they need it, well, artificial intelligence can augment the capacity of clinicians, of healthcare professionals, of nurses, of the admin staff, so that we can maximize our current workforce, so that we can be much more impactful in improving people's lives.
Ricardo, if the potential health benefits are that significant, what sort of investment is needed to make it happen?
Well, that's a really important question, because we are seeing a lot of companies right now with amazing innovations, but they're hitting a brick wall. We see a lot of pilots, but they're not scaling towards the systemic transformation we would like to see. So the question is why? On one hand, there's the issue of trust. And that's what at Health AI, working with governments, we're trying to build the governance system so that we can put in the proper ecosystem in terms of regulatory maturity, so that governments and regulatory bodies are more capable to respond to the needs of AI, and so that citizens and healthcare professionals can trust the technology. But then there's the money issue.
Yeah, who's responsible for that investment?
Right, and who's going to pay? Billions are being invested in research and development. Who is going to pay? Well, if we want to make sure that this technology reaches everyone and not just a privileged few, health systems and insurances will have to step up. But the problem is right now we don't have the health technology assessment models in place so that we can assess the technology. This is incredibly important. It's part of our work with governments, which is how do we separate on one hand the snake oil from what is actually working, because a lot of technology that is being promised out there is actually not that effective. So how do you separate those two? And out of those technologies that do work, how do you make sure that you're paying the fair price? And so developing those models will be critical so we can go from the pilot stage we are in today, so that we can scale technologies, and those technologies can help the systemic transformation.
Is it something governments can realistically fund, though, or do you think we need to lean more on the private sector for this investment?
It's interesting you say that, because when we look at AI in health, or AI in general, when you look at the United States, it's primarily funded by the private sector, venture capital.
Yes.
When you look at China, the other big powerhouse, it's mainly state-driven. I think this is actually the biggest opportunity for Europe, which is to be right in the middle, to bring together the public and the private sector to work together. If Europe is able to find that solution, and I think it's critical that the European institutions understand that they need to work closer with the private sector, that the regulators need to create a pathway of conversation with companies developing the innovations from the start, from the moment they start developing the technology all the way to access to market. If we can find that perfect balance between private and public sector, Europe can really take a step forward and potentially overcome the lagging that we are right now. If you look at patents report, the latest global AI patent report shows that 61% of all AI-related patents came from China, 21% came from the United States, 2% came from the EU plus United Kingdom.
2% from the EU and UK combined.
And if you look at patents as a window into the future, that is a concerning figure. So we have to, I wouldn't say that bringing the private sector into the conversation is an option. It is mandatory that we all work together.
Wow, that's really insightful, Ricardo. And you highlighted yourself trust. And of course, that is a key issue when we talk about AI, especially in healthcare, and I'm thinking data. But before we go to data as well, the other thing that springs to mind is of course, when you're relying on AI for healthcare decisions, who's ultimately accountable?
Well, that's one of the challenges that we have to address, because almost every survey we've seen globally where there is hesitancy in the adoption of artificial intelligence, almost consistently, it is the healthcare professionals who are not adopting the technology, either due to lack of trust, they don't understand the technology and therefore they don't trust the clinical decision support tools, for example, or because they are fearful of legal liability. So, as you were saying, if something goes wrong, who is responsible? Today, in most jurisdictions, it'll be the healthcare professional. And that is the reality we have to work with. So we should see these technologies as augmenting and complementing the work of clinicians, of nurses, of pharmacists, of healthcare professionals globally. But ultimately, the human-in-the-loop factor is where we are today. The way it's going to evolve in the future will very much depend on how the technology evolves and how the regulators adapt to that. We need to be in the forefront, and Health AI is clearly positioned to do so.
And realistically, how likely are errors compared with human clinicians?
Well, the truth is it depends on which sector. And there are sectors where AI is clearly much more efficient at making sure that we are achieving certain outcomes in comparison to humans. In some factors, the combination of human plus AI is better than AI alone or human alone, but others, AI alone is significantly better. So there's not a one-size-fits-all response to that, but I can tell you that's not enough for a technology to survive. I'm not going to mention the country, but I met a company that had an amazing imaging technology to detect breast cancer. It had the capacity to detect imaging several years earlier than the human eye. And so we're talking about saving lives here. The company went bankrupt. And the reason was because the government, well, the governmental regulator at the time responsible for reimbursement of the technology told them that they would take 7 years to assess the technology before they could consider reimbursement. So it all goes back to the factor, it's not just about the technology, it's making sure that you choose the technology that can transform the system, but also creating a model in which it can scale, and the reimbursement and health technology assessment is critical in that aspect.
Yeah, really interesting, really supporting innovation. And then, Ricardo, on the data side, as earlier noted, AI thrives on data, but health data is sensitive. How can we guarantee privacy and security while still, of course, allowing AI systems to learn from medical data?
So I think here in Europe, we have a huge advantage in comparison to other jurisdictions because we have already a lot of frameworks and mature regulation when it comes to data privacy, when it comes to European health data space legislation, which can be actually incredibly impactful even in fostering innovation if it's well implemented and ensuring access to the data for developers. But the question I would ask people to think about is when they travel around the world, they go with a credit card in their pockets, and they can withdraw cash in any ATM machine around the world, and it works. And our financial data is highly sensitive. We don't want people to know our financials. We don't want to lose our money in our bank to someone else without our authorization. Yet the financial sector has been able to put in the incentives within their commercial model so that it has a global system. In many parts of Europe, if I go to a hospital or a clinic and I go to the clinic across the street, they don't know, they can't access my health data. And so there is a fundamental problem that we need to solve. And that's where I think the European health data space legislation could be a huge opportunity, not just at the European level, but at the domestic level, where governments need to prioritize. Many times people ask me, if you were responsible for choosing the first thing to invest in terms of ensuring AI will be successful in your country, it starts at the data. Make sure that you have access to the data and you're providing access to the data and creating incentives for citizens to be part of the process of providing their own data. Under GDPR, people have to proactively say that they accept to share their data. Why is it that only a few big tech companies are making all the money off of our data? Why don't we create a model, for example, where if that data is a commodity and it's worth money, why can't we redistribute that money to the people? who share their data and create a model through which we can incentivize, even through financial incentives, so that people can be part of this process and control how their data is being shared. So the technology that today exists, and now with the power of AI, there are huge opportunities to have data governance models that can accelerate innovation, but most importantly, improve health outcomes for all.
Ricardo, thank you. And of course, it does take time to build that trust, as we know. There's also an AI race unfolding globally, particularly between the US and China. How should Europe position itself when it comes to AI in healthcare?
Well, as I said, I think that we have the opportunity of bringing together a mixed approach, the private and the public sector working together. I think that would be fundamental. And we have, as we heard just in the previous panel, amazing technology companies here in the region. When you're talking, when you're talking to industry partners and governments that are trying to say, how can we be more innovative? How can we foster innovation in our ecosystem? Many times there's an idea that you have to privilege one company over the other so that they can boom. But what I hear from the company side, from the private sector innovator side, is we don't want necessarily that kind of differentiation. What we need is for our health systems to absorb our technology, to show that it works, so that we can export it. And so what we're doing at Health AI, for example, we've created a directory that puts together all of the technologies as they are approved within the health systems. So it's a global marketplace, so everyone can see what technologies are out there, who developed them, and which regulators have reviewed them. Europe should be at the forefront at showcasing its technologies, creating use cases within our market, creating scalable technological breakthroughs that are transforming healthcare in a way that is measurably improving people's lives and become the benchmark for the world. Europe, as a single market, has that opportunity. It has the technology, it has the knowledge, it has, I would say, even the political will. Now we need to transform that all into action.
Indeed, there is the political will, but Ricardo, Europe is also known for taking a very cautious approach when regulating new technologies. And of course, as you said, there's the benefits. The GDPR, protection of data, are crucial. But in your view as well, are there any current EU rules that are around AI helping innovation in healthcare, essentially not helping innovation in healthcare, but slowing it down?
Well, I think there was an acknowledgement from the Commission that the European AI Act, which, of course, addressed the issue of medical devices, along with the European medical device regulation, there was somewhat of a mismatch. And so there is an acknowledgement that that needs to be fixed. We cannot complexify what can be simplified. And the commissioner today said the goal is to simplify processes. This is a good place to start. But that being said, I think that we have an opportunity in the region to understand that when it comes to healthcare in particular, and we're talking about this specific niche, this is a market where the technology, when it comes to AI, will not scale if we do not trust it, going back to the trust factor. The only way to trust technology, especially for citizens and healthcare professionals, is if you have the proper regulatory environment in place, the proper governance in place, the post-market surveillance in place. Mind you, the future of AI is an adaptive technology, a technology that learns as it moves. I foresee that it'll be much more important, the post-market surveillance of these technologies, than the pre-market approval. The way the technology enters the market will be very different than how the technology then evolves. You need to have mechanisms in place, just as you do for pharmaceutical products, to detect if something is going wrong as the technology is evolving. And that's why we've created at Health AI a global early warning system, working with regulators to detect problems early on so we can fix them and therefore build trust. So everyone knows there are agencies in the governmental side looking out for how the technology is performing. I believe that Europe is uniquely positioned also in this space to build up on sometimes what we criticize of excessive regulatory compliance. We should use that in the benefit of transforming a sector that so much needs reform, which is the health sector, and demonstrating how that can ensure that everyone can benefit from improved health outcomes with the power of AI, particularly those that systematically, due to their poverty situation or their vulnerability situation have been consistently left behind, AI presents to us an opportunity to ensure that everyone can have access to the health they need.
Ricardo, on that note, thank you very much for joining us on The Big Question. We are going to have to end it there, but it's been great to get your insights on this. So thank you very much for joining us on The Big Question. Thank you very much. Ricardo Baptista, later CEO of Health AI. Thank you very much. Do take a seat. Thank you. Pleasure. And thank you very much to all watching at home. That was the latest episode of the Euronews flagship program, The Big Question, one of our business shows. And you will be able to watch more episodes of that as well on the Euronews website and also on our YouTube channel. Now we have more on AI, this time a panel debate. And the title for this is AI in Health, Where Do We Draw the Line? And so we heard as well from Ricardo there, his insights on this. So we're now going to explore the intersection of tech and healthcare again in our next panel. But again, looking at how AI is rapidly advancing from analyzing, as we heard, medical images to accelerating as well drug discovery. But with this innovation, of course, comes important questions. And you just heard some of them, and we're going to hear more now. And it is my great pleasure to introduce my colleague, Pascal Davies, who is going to moderate this discussion. So please welcome Pascal to the stage. Thank you very much.
Good afternoon, and thank you. As Angela was saying, we hear a lot about the promises of AI, especially in healthcare, when it comes to drug discovery in particular, but also helping radiologists maybe discover cancer before the radiologists even do. And we may even see robots taking care of ourselves in the future. But with that, there also comes a lot of warnings. So misleading health advice for one, and also who bears the responsibility of AI decisions. Today, we're bringing together health business leaders in clinical health and AI, and even the European Commission, to get a really healthy debate going about AI and where do we draw the line. Please welcome to the stage Professor Christian Doehler, who's the Vice President of the Max Planck Society, Simona Moors, who's the Senior Policy Officer at the Guild of European Research Intensive Universities, Olivér Várhelyi, the Head of Unit Digital Health at DG Santé of the European Commission, and Jan Wilhelm Schrijdgrond, who is the Vice President, Global Head of Government and Public Affairs at Philips. Thanks for joining today. So let's get right off into the debate, which is the promises. So what are we actually seeing in AI in healthcare today? Where are we seeing the most advances and not just the talk of tech companies? Olivér, go ahead.
Oh, sorry. So thank you very much for inviting me today, and I'm happy to be here. I mean, it's everywhere. That's the question. That's the point. AI is today really full of promises in all different areas, from diagnosis to treatment, from really relying the administrative, relieving the healthcare professional from administrative tasks. It is supporting the hospital managers in organizing the work in the different dispatching resources across the different sectors. So it's everywhere, and we know that the healthcare sector in Europe and also around the globe is facing enormous challenges in the short, medium, and long term. And the AI is definitely a part, not a silver bullet, but a part of the solution. And that's where we're really looking forward to exploit that potential.
Simona, can I ask you, where are we seeing most of those advances at the moment? Does it come to administrative officers? Is it in the healthcare itself? Is it in diagnosis? Where do we see the most benefits at the moment?
Yeah, thank you for the question. Also, thank you for having me. And I think it's a very interesting question, because when I first thought about the question, I was asking, like, there's so much, like you just said. It's like it's very hard to pick just one, because depending on where you work and what's your field of expertise, this is the one part that you see as the most essential one. But one of the things that really stood out when I also discussed this whole topic with my AI working groups is that there are, of course, specialized systems that are designed for defined tasks, such as, for example, image analysis, but also risk prediction and just also the workflow optimization that you were talking about. So in this experience, we suggest that the near-term future of AI medicine, it's not just necessarily of what kind of AI tool there is, but more about the collaboration with the human. So therefore it's between the specialized AI tool and the human expertise, so the medical professional. And in the end, I don't really think that AI will replace the human expertise anytime soon. So it's more on the assisting and the knowledge sharing, let's say.
Okay, so let's get to the risks then. And so if we're putting these AI systems in the hands of doctors, yes, it can help them, but what if a diagnosis isn't correct? Who then bears the responsibility?
Let me maybe first start. I'm working for the Max Planck Society and we're doing basic science. So we make discoveries in all different scientific and academic disciplines. And for us, we see the tremendous success of AI. So I would first of all argue that we should have a very open mind for the potential of AI, and a little later talk about the risks, because in basically all disciplines, whether it's quantum physics or neurosciences is my discipline, or also sociology, discoveries are made with the help of AI. And it's just a fantastic analysis and discovery tool in the sciences, which can then, of course, have a huge impact on health sciences and then at the end in the clinic. When we talk about risks, of course, I think it depends on the data on which we apply AI, and there we need to have sensitivity, of course. Health data are, of course, very critical data, but if they are anonymized, then I think it's important to train the models with the best data, and if they are anonymized, then at least we have some sort of risk control.
We'll get onto data in a moment, because I know that's a big topic that you're all going to want to chip into. But I want to ask your input, Jan Wilhelm, from the business side of things. Who bears the responsibility of these AI systems?
So I think the important thing is to understand what AI can do and what not. And I think there's a super excitement about AI diagnosing and treating and all that. We're not there yet. But if we look at the healthcare sector, where we are, is that 30% of data in the world is healthcare data. And it's all nicely locked in silos. So you think your TikTok movies and all that are full of data. Think about healthcare. It's the biggest source of data, right? So if we are able to unlock that data, how are we going to use that responsibly? Now, most of the uses are actually in workflow optimization, doing stuff more efficiently. It has nothing to do with healthcare. It's just, I'll give you an example. A patient comes into an emergency care room, maybe has a stroke. The system can already set that up, checks it in from the check-in. This is a stroke. We need to do a stroke exam. Let's do a CT scan. Let's identify whether there's a clot in the brain somewhere. Give it to the doctor. The doctor can see, this is the picture I need to look at. And then say yes or no to a stroke, and then save minutes. And with stroke, minutes is a lot of brain cells. And so this is just workflow optimization. So you see most of the applications in AI is making things more efficient. Not doing the diagnosis, not doing the treatment, making it efficient. And healthcare is, there's one thing that healthcare misses is time, right? Everybody is stressed out. And to exacerbate that, everybody wants more diagnostics imaging. In the 90s, when you came into a hospital and you wanted a CT scan, you get about 20 images, 20 slices of whatever lesion or something in your body. And the radiologist would look at 20 images, put them next to each other, say, that's the picture I need to look at, you've got this. That's the diagnosis, human, right? Now you got a few thousand images. That same radiologist, we haven't got a few thousand more radiologists, same radiologist has to look at the few thousand images. So the AI is there to help the radiologist ignore those pictures, look at those, yeah? And then when it comes to responsibility, yes, well, there's liability legislation that is functioning very well for medical devices, also for AI, so leave that aside. But of course, when you develop AI, you got to think to yourself, how am I going to be responsible in this? And so we've developed a compliance mechanism, but I think most of the medtech companies apply similar principles. I said, the first question you ask is, can we, technically, can we do this? Can we use AI to technically diagnose this or speed this up or help the clinician in a particular way. Second thing is, are we allowed to? Does the law allow us to take this risk or use it for this application? And thirdly is ethically, should we do this? So can we, are we allowed to, should we do this? I think every self-respecting company and organization will try to have a compliance mechanism like that. And then of course when it's about ethics, and you already referred to it, what are we looking about, for example, bias? So we've created a bias framework. There are about 30 different kind of biases that we have identified in diagnostics imaging. So gender is one bias that you all recognize, but there are many, many more biases that are in the system that doctors also experience, but that we can actually help improve. And if you then look that doctors are right about 75% of the time, AI is right about 99% of the time. But most of us don't think 99% of the time is good enough for workflow, but 75% for a doctor is fine. So we also should be looking at taking the responsibility that we compare apples and apples, we compare doctors and AI, and we don't ask suddenly ridiculous kind of things from AI, and therefore also stifle innovation, that we're not even asking from our current healthcare system.
Okay. Fulvio, can I come to you? Do you think those kind of mechanisms that he was just talking about, do they go far enough? And that's open to everyone. Or do you think there should be something that should be improved?
Okay. Well, I think at this point, it goes far enough. But of course, it always needs to be appropriate to the situation. So it's in healthcare, especially, no case is like the last one. So if we, of course, go through certain triage systems and in healthcare, there's always, every patient, every human is different. And so this needs to be taken into account. This is where, from other sectors, health in AI is different, and it's completely different because it's also, everybody expects this specialized treatment as well. And so I think that really needs to be taken into account. On the rest, I would need to reflect because that's a very tough question. Thank you.
Anyone wants to jump in?
Maybe one thought experiment, not necessarily restricted to health sciences or the clinic, is we always try to assess the risk of applying AI. What is the risk of not applying? Yeah. And I think that's a useful exercise to think that through.
And if I may, I think that the key element here is to build up the trust in using the AI or in seeing the AI applied in my specific case when I'm going to the hospital. This requires a lot of conversations between the healthcare professional, training on that side to explain, to make more transparent, and on the patient side as well. So we need this element of transparency to be sure that the patient is properly informed about the fact that the involvement of AI in their process. We need also indeed the trust in the use of data, you mentioned already, and we may speak about it afterwards, but with the European Health Data Space, that's the element that we're bringing into the game. This must remain at the center. If we build trust, if we are able to have that trust in the use of AI, then indeed, we may also reduce the fears and this connection about the risks that the AI would entail into the processes. The big advantages of AI will come when it's routinely integrated in clinical processes, when it becomes something that is normal because people trust as a normal radio system or an IRM or whatever. I mean, it becomes normally included, regularly included in clinical processes. At that point, then we'll get the benefits out.
Okay, Jan.
Yeah, the trust element is very important. We have at Philips, we work with an index called Future Health Index to understand what revolutions are happening in healthcare and how is that going to transform your lives. And we asked thousands of doctors around 20 countries in the world to say, okay, so how are you thinking about AI? Are you trusting it? Are you confident that this can actually help you? And so last year, for the first time, we saw that 80% of the doctors said, yes, this is going to help me. But then you ask the patients the same question, and they were a little bit more reluctant, like 60%. But then when the doctor advises the patient to use the AI that's going to help them, then suddenly it goes to 90%. So the doctor is the most trusted professional in the world still, more than church, and more than politicians, but that's easy. But so the doctor is really trusted on everything you do. So if the doctor says this AI is going to help you, the confidence and the trust in the AI becomes really important. So it's important that we convince the doctors, or that we help the doctors address. And that means that the doctor stays in control of the data, humans in the loop of the decision making, and that the accountability stays with them about decision, and then we understand what the AI does. So we are spending a lot of time to explain that, and we do that in the industry, because if we don't have that trust, then we lose the AI opportunity.
Okay, I want to move on to data now, because it really is the heart of what makes a good AI system or not. As you pointed out, a lot of the data is trained on predominantly white male. So does this create a big disadvantage when using AI, and can we really trust those systems if this is the data that's available?
If I can start even, because indeed, if it's not properly addressed, it can really worsen the situation we're in right now. And we do have to also face out the uncomfortable truth with how current AI systems are trained, and also on how healthcare is also shaped for a certain part of the population, like you said. And this is really a big point. So there are, of course, underlying factors that needs to be addressed in order not to perpetuate this or make it even worse. And therefore, of course, it's the diversity and also the quality of data which are essential. So in the end, especially in Europe, having such a diverse population, it's initiatives like the European Health Data Space, of course, that helps provide also larger and also more representative data set and more, more data in the end. And I think from that, it's also important to have the clear communication about the benefits, but also about the risk and the limitations that is evident, and to make data sharing essential to also ensure that the research is representative. So if we look, for example, on the opt-out mechanisms as such, which is a big part also of the European Health Data Space. I will have Fulvio next to me here, the pen holder unit of the data space. But in here, it's really essential that we need to have to make the communication right, because if we, this is the responsibility of the member states in the end, and the Health Data Access Body, to really properly communicate on the data, on the representation to all aspects and all fora of the community. So it's really essential that everybody understands this. And lately is, of course, also the independent scientific validation. So coming from the university sector, of course, the AI system requires rigorous evaluation before the deployment, especially. So really the scientific community is the one that also plays a big role in the independent performance on evaluation of those systems. So this really needs to be addressed, and that we have access to the data.
Christian, from the scientific community,
I mean, in terms of the
reverse this?
Yeah, in terms of the biases in the system, I think I'm not worried, because there is an increased awareness and sensitivity for several years now that medical research, health sciences have had limited possibility of generalization, because, I mean, start with the laboratory animals. If they are only male rodents, then it is difficult to generalize these findings to all genders. So what I'm saying is there is a high sensitivity in medical research already to have a much more diverse research subject. And if that spirit is taken to the development of AI and to train it on diverse data, then I'm not worried, actually, from a scientific point of view.
And from the business point of view?
So there's been some brilliant work done by ethicists, a difficult word, about biases in the data. And of course, white male data is the cheapest, most readily available, especially if East Coast the United States. So you can get that data very easy. And there are right and wrong reasons why that is. But the ethicists have said, look, if you're looking at how much the data influences the outcome for other populations, you need to look at fairness. And so you can say, well, if this is the group of data that I have for men, and that gives me a reasonable confidence in outcomes that's this high, and this is what I have for women or children or whatever, and the outcome is lower than I would normally expect it from a trustworthiness perspective, there are two ways of what I can do. I can either dumb down the male data to the same level of confidence, or I do an extra effort to increase my level of confidence of the women's data or the children's data or whatever bias group you're doing. And so I think those are strategies that data scientists are using. So what is important is to understand the bias that you have in your system and how important that is, and then work on it. Now, so we do that. We have a business bias risk assessment. I think a lot of other companies do that as well. It's important that those skills and that practice is being adopted and checked. Now, does that mean that we need to draw a line and saying that, until here it was bias and no further? No, we don't know how bias is going to play out, to your point, what we learned from science. But we do need to draw the direction in which we do. So we need to give people the tools to start working with this, understanding bias, fairness, transparency challenges, so that we can start to benefit in the same way as we've done in health sciences in the past.
And Fulvia, can I bring you from the regulatory perspective?
Yes.
Is this even possible? Because you get a lot of critique that there's too much regulation, meaning that there's not enough access to data.
Well, let me say, first of all, that we have been spending now the last 5 years, the previous commission, in drafting the regulation. Now it's the time for implementation, and I think we're working very hardly to make it working in practice and delivering its benefits. Specifically on the data, of course, we expect the European data space to support and to correct to make the data available that would help, let's say, researchers on one side, the manufacturer on the other side, to correct this bias. Because the idea here is that all data, not only the one collected for research, which are very well cured from the beginning, but all data which are collected also for treatment diagnosis at source, so for care purposes, they are in the scope and could become available for the research of innovators. So tomorrow, through a very solid governance system that we're setting out together with the member states at this point in time, through secure processing environment, to ensure that those data can become accessible only under very, very secure conditions. We also, in the HDS, providing us very clearly what are the uses which are allowed, what are the uses which are prohibited. For instance, re-identification or even profiling. It is explicitly forbidden in the regulation. That's again to provide trust, and with that instruments, we hope to make it available really for the researcher and the manufacturer on the other side. One of the largest availability of data in the world, because we're moving from a cohort base, which is the actual core basis for the research innovators of tomorrow, to a population based. Indeed, there is we need to work very carefully on the possibility of doubt. This is a right. Member states have to set up systems for allowing the citizens to opt out from the system. I think there is indeed a matter of communication on really reassuring the members, the citizens about the use of this data, and linking together actually the use of the data with the benefits that we can expect from more AI, more digitalization in the system. So the more we can build this trust element on the use of data, and then the more we can really rely on solutions which are based on reliable data.
Okay, I want to come to speaking about the startups and the researchers, which Europe has world-class expertise in this, but with limited access to data, is that going to hinder them? And is there any way to kind of help that? So let me come to you, Christian, on that.
Yeah, I think, access to data is very important because so a couple of aspects on the data. Access to the data is important, but then, and at least the health systems, I can speak from a German perspective, is very fragmented. So too many stakeholders are involved in the data acquisition. Some people sit on their data, they don't share the data, but it's also the quality of the databases. Are the data clearly identifiable, for instance? And for medical research, I think, because I see the potential of AI in health science, in particular in predicting diseases, identifying small patterns of variation, and there the longitudinal perspective of the data is important. So having data from the same participants and patients over several measurement time points, and so I think this is crucial to train the models well, because only the well-trained models can predict the future better.
And a lot of the health startups I speak to in Europe, they say a lot of the issue in them really advancing is that they don't have as much access to data, say, as in the US or China, which, you know, on one hand, great for patients, on one hand, not so great for those companies. So is there a way for them to kind of really push and, you know, be competitive in Europe?
If I may briefly add on that, I think it doesn't always need to be the very big aim. So maybe for Europe there's a chance of focusing on specific aspects, specific questions, and then AI companies focus on that, so that they might need less data for that if it's a dedicated question rather than an overarching question. I mean, that is maybe not the solution for all the challenges, but specialized. What is the added value? We don't need to repeat what other big companies have been done in the past. So this is at least one way to go.
Mm-hmm.
So the commissioner was here earlier saying that, you know, the medtech industry is quite unique. There are like 1 million people employed, 38,000. I think he said 34,000. I have figured 38,000 SMEs in Europe that are working on innovation. But what you see is that a lot of those are having trouble growing. Now, I cannot believe that any of them is not working on AI. So they're all working on AI. Let's assume that. So that's why I'm so excited about the European health data space, because in Europe we have the most diverse data set in the world, right? I mean, if you look at Europeans compared to anywhere else, wow, 450 million of very diverse people. United in diversity, I think, is also the motto of the European Commission. There you have it. So if you unlock that, then you become the most competitive ecosystem for innovation in the world. If you don't, then indeed it's the United States and China. Now, United States has some scale, but not that big, because there, the hospitals, they don't know how to exchange data either between them. So, but they have a few million here, a few million there, whereas our hospital chains are smaller hospitals with a few 100,000 here, a few 100,000 there. So that scale is limited to a university hospital or a hospital. And the networks in US are bigger. The networks in China are government networks, right? So you can't compete with that. So we need to make sure that we really unlock that data easier. Now, for a company like Philips, if we want data from a hospital, we do some research on AI, it takes us 1 year. We spend 9 months on the contract, on how to disclose the data, and 3 months on the research. Now that's wrong, right? And that's different in Europe than it's everywhere else. Can you imagine, we have a lot of lawyers at Philips, can you imagine if you're a small and medium-sized enterprise, you're negotiating with one hospital to do their research, and you've done it, it's a success, you go to the next hospital. Again, they will spend 9 months, probably 18 months negotiating how to use the data, and then 3 months to do the research. If we can unlock that and do that differently, then I think Europe can be the best place, because the other thing that the commissioner said is citizens should have the access to the best care possible in Europe. Well, if that's your ambition, you need to make sure that you have the best possible innovation. So my conviction is that you need the best regulatory system in Europe, better than the US and China. That means also how you regulate AI and the medical device regulation. You need to have the best innovation ecosystem. That means you need to realize the European health data space. You need to make it automatic. If I want data from a couple of hospitals and I want to innovate, click, sign, pay, innovate, right? That's what you should be doing. And then Europe should become the best place to also produce. That was the previous panel about how do we make sure that we have local production, sovereignty, if you like, or resilience, or the different ways of describing, or employment, and take it from 1 million to maybe 2 or 3 million people that are working in this industry sector. And I think we have gold in our hands, but it's also time to realize that AI is going as fast as cloud, and we know what happened to cloud, we missed the boat.
Okay, let's come to regulation, Fulvia.
Yes.
What is the EU doing to boost these kind of AI startups?
Well,
and is regulation proving a hindrance?
Well, first of all, we're making the European health data space on a daily basis, and working with the member states, full speed implementation, implementing us, technical specification. This all is going, and is going to provide really the basis for a system that delivers in terms of data. And this is very clear also for SMEs, because at the moment, and smaller research centers, because indeed at the moment, as you mentioned, it's very complicated to get an access to data. While through the system that we're setting up with a European health data space, the procedure would be the same for SMEs or a big company. So really opening up a market really for those companies as well. Always, of course, under very strict confidentiality and conditions. Then what we're doing is also that we're looking at AI in broader terms with the colleagues of DG Connect. Of course, we had the EU Apply strategy very recently to look at the underlying conditions for picking up the AI across all sectors, with a specific flagship on the AI and pharmaceutical industry. In particular, I think it's very interesting to know one of the flagship is the setting up of a user community. So it's a multidisciplinary community that would really look at ways to promote the deployment, the uptaking of AI technology in hospitals. So really providing very practical, let's say, tools in the hands of the hospitals to understand where the AI technology fits in that process, how to restructure the process in a way to maximize the benefits. And this is something we're doing, as I said, across regulations. So to navigate in the environment, which of course I'm not going to deny that is complex, but is also creating a very solid framework for this deployment and to build up that trust that we spoke before. So we're working across the HDS, AI Act, MDR as of today, of course, and in vitro regulation, as well as the GDPR, because it is a complex, but it's also setting very clear boundaries for the people that is investing in this area. And as I said, we do our best to help the different actors to navigate in this environment, so to have that framework guiding and promoting and providing security in the medium long term, also for investments and designing the future, more than actually indeed setting barrier limits, let's say.
Okay, Simona, let me come to you. The AI Act, we've also got the medical devices regulation. There's a lot of regulation out there. Is it easy for these kind of AI companies, the startups in Europe, to navigate?
That's a very tough question also that I've been previously involved in with the AI Act when it was still in the negotiation phase. So it's very interesting to see now also with the simplification of the AI Act and with the revision of the MDR and the IVDR, how will this all work in practice? And I think an overlap could potentially create friction, and I think this was also one of the concerns from some industry stakeholders as well. But of course, the EU is currently actively correcting it because it learns. It's not the fastest machine, as we all know, but it is still working very actively, and so I believe that the situation is a bit more nuanced than we would just say double regulation equals slow access. So the biggest risk so far is that it's not necessarily, as I said, duplication, but it's the clear operational guidance that is needed to really understand from an SME perspective, from a researcher perspective that is, as research is formally excluded under the AI Act, to see, okay, where do I fit in all of this? So it's really more about clear communication and guidance, and as well also that, like we talked earlier, AI systems, how are they developing and continuing once they are already put into market? So this is a really particular point that requires a lot of, nuancing, and so. This is really of the important challenge is the coordination and the timing as such. The rest, of course, the text and the guidance is really needed to this, so to really help people to understand what do I have to do when, etc.
It's a tough balancing act, and with a technology it's developing so quickly, there's a lot of work to do for you guys at the Commission, of course. Okay, so I want to kind of start to conclude as we get to the end of this. And go back to our initial question, which is, have we crossed a line? Is there a line? Is there a line we must never cross? Or if we have crossed a line, can we prevent it? So to each of you, let me start with you, Christian.
Yeah, the limits are the constitutions, the human rights, of course. When we talk about the European Union, the constitutions of the member states, and this is the absolute line. And then we need to assess. I mean, in the AI Act, there is a risk assessment, a nomenclature. Whether that's the optimal one, we need to see in practice. But of course, there are some lower risk areas and there are some higher risk areas. But I would argue, when the narrative in the media, when you hear about AI, it is usually a negative connotation. It's very often the case. When you open the newspaper and there is an article about AI, it's usually 90% of the cases it's an image of a robot. I mean, AI is software and it can guide a robot, but it's not a robot. So there's a lot of misunderstanding. That brings me to the beginning of everything. I mean, it's education. I think we need really good education at schools, sensitivity of developing AI, applying AI, and a positive, open mindset. Usually in the history of humankind, technology made our life better, and we should take that positive spirit, I think. And of course, checks and balances are important.
So we haven't crossed the line yet?
I think we haven't crossed the line, no.
Well, yes, same question to you.
I think the line that we should not pass on is the one that put at stake the safety of the patient and the people. That's the bottom line. We need to build and to design together a line that actually brings together and links together the innovators, the one that you as you do. They are developing the AI tools that they are putting with the users, and connect what you're doing with the benefits at the end for the patient, so that we can really get together and having this connection between the potentiality, which are potentially infinite, to the actual benefits that these algorithms and those technology can bring to the patient and to the people. That's the line that we need to design together. I mean, to really build up a trust relationship and to exploit potentialities, which are, as I said, enormous.
Simone?
Yeah, I think when you talk about the line, my first question is, what line are we talking about? So I think one point that really strikes me, and this is something that we really need to be mindful of today and how it is implicating the future, is the ethical line of AI in healthcare. Because we're making decisions today, we lay the groundwork, like, for example, with the European Health Data Space, with the revision of the GDPR and the medical devices regulation, et cetera, et cetera. And there we have a moment and we have a momentum where we can really make an impact, but we need to understand of where does this impact, or to what leads the impact in the future. Where we stand right now, our decisions today, what will they have for an impact in the future? And as such, we really need to have, and I'm coming from the scientific perspective, but to really have the sound scientific and validated evidence to make informed decisions that are based on robust data. And so that's one point. And of course, now the topic on trust, we talked about this before, and especially on health, especially with AI, we see it over and over again. In the end, the trust itself is really slowly gained. You need to understand very slowly how things are working. And then the moment something does not work, this trust is very fastly broken. And so this, especially right now, we are on the crossroad to see how we're going to do next.
So is that doctors' trust, patient trust as well?
I think it's everyone's trust, because we are all patients, we're all citizens that are patients. Doctors are patients as well. Doctors are using the artificial intelligence. It's about the administrative staff that works on this with the workflow. So it's everyone's, because we all see what happens if you have a system that does not work properly, and then you have to live with the consequences from an institution's perspective.
And Wilhelm, do you think there is an ethical line when it comes to AI in healthcare, and are we near the line? Have we passed the line?
No, I think I agree with Simona. Which line are we talking about? I think we've started, so we've crossed the starting line with AI. But the challenge is we're on a journey that we're actually not quite sure where we're all going. So, and there are a couple of people around here, Fulvia is one of them, who can actually help us build some guardrails so that we don't fall off a cliff, right? So that's quite useful if you're going, everybody's excited and running, and yes, this is the AI opportunity. And so you need some guardrails, and that's why I'm, for example, a big fan of regulatory sandpits. The NHS has already experimented with it in medical imaging and radiology and AI, and say, okay, so how can we help you carry on in this journey. You've started, great, fantastic, and then help you along the ways to stop crossing any ethical lines or regulatory lines or liability lines, whatever lines there are, but also carve out a direction that we think this is also a societal need. Are we making AI that's actually relevant for patients? Are relevant for society, relevant? Is it reducing cost? Is it improving access? And so that's also a direction. And I think that's where politicians and insurance companies come in and say, look, you know, mental health, big issue, right? Half the healthcare burden. You know, if you give that to all of those innovators that we have in Europe, they'll love a challenge. And that's where you have your innovation instruments, Innovative Health Initiative, for example, to stimulate AI development in certain directions. So it's push, pull, and protect the guardrails. Now, AI is just a tool, right? It's not the solution to everything. Not everything is going to be solved by AI, thank God. It's just like technology. And don't forget, in medicine, we started working with X-ray. Oh, we thought it was a good idea to put X-rays through people's bodies to look at the bones. You know, if you'd start with that now and say, you sure you want to do radiation in people? So, of course, we had to learn to put guardrails in place there and standards and experimenting with that. And then software came across as a software. We're going to outsource something to an invisible one and zeros. So software, technology, AI, it's all part of a mix. AI is the new kid on the block. We can embed it. And once we, at the end of that journey, we'll know, because something else will come up, and we'll have integrated it. We trust it, we understand it, and we can, in particular, innovate and address the challenges that we see in Europe, and possibly create a very healthy economy and a healthy society in doing so.
Okay, well, let's hope for that then. Thank you so much to our panelists today for that great discussion. Data clearly is key here, and so is ethical responsibility, but it sounds like you guys are all working on it, so thank you. So I'd like to thank Professor Christian Doehler, who's the Vice President of the Max Planck Society, Simona Moors, who's the Senior Policy Officer of the Guild of European Research Intensive University, Fulvio Raffaelli, who's Head of Unit Digital Health at DG Santé at the European Commission, and Jan-Wilhelm Schödegrond, sorry, nearly.
Perfect, yeah, perfect.
He's the Vice President in Global Health of Government of Public Affairs at Philips. Thank you so much.
Thank you very much, Pascal, and thank you to all of our speakers as well. And that was certainly a reminder to me as well when I was listening from over there that indeed AI is not this robot that we just see, or ChatGPT that we get our medical advice from sometimes, which we certainly shouldn't be doing, I know. But it's a reminder, as we heard there, of the benefits that AI also brings too. So we have covered a lot of ground this afternoon, how AI is evolving in healthcare, medical sovereignty. So it's now time for you all to digest that with some food too and some refreshments. We will see you back here at 4 p.m. And this afternoon, the session will be hosted by my colleague, Marid Gwyn-Jones. So please do go and enjoy some refreshments, and we'll see you back here at 4 o'clock to continue the Euronews Health Summit. Thank you very much.
Good afternoon and welcome back to the Euronews Health Summit. I'm Marit Gwyn and I'll be guiding you through the remainder of the afternoon. Thank you to my colleague Angela Barnes for her work throughout the beginning of the event. Now, we have an audience here in the room in Brussels, but we also have viewers tuning in at home, watching across our social media platforms, but also on TV. We are broadcasting across our 9 language channels in 160 countries. Now, next, we have a little bit of a treat for you because we're moving on to a live broadcast of one of Euronews' most popular shows, our weekly debate show, The Ring. It's hosted by our chief anchor, Maeve McMahon. So please welcome Maeve to the stage.
Thank you so much, Marit, for that very warm welcome, and welcome to you all here in the room and, of course, those watching back home. So, welcome to The Ring, to this very special edition, broadcasting live here from downtown Brussels. My name is Maeve McMahon and I'm one of the presenters of The Ring, which is our weekly debating show that sees MEPs go face to face on some of the most pressing issues of our time. The topic that we're jumping into today is healthcare and who should pay. Let's meet our panelists.
A Luxembourgish MEP from the Greens European Free Alliance Group. She has been a member of the European Parliament since 2018 and serves on the Committee on the Environment, Public Health and Food Safety. In debates on EU health policy, she has advocated for stronger European cooperation on public health and greater transparency in the pharmaceutical sector. We need a strong commitment to solidarity over privatization and to high-quality care over commercialization, she said. Stine Bosse, a Danish MEP from the Liberal Renew Europe group, elected to the European Parliament in 2024, she works on economic and industry-related issues and has spoken about the importance of maintaining Europe's competitiveness and innovation capacity. In discussions about the pharmaceutical sector, she has emphasized the need to balance strong research incentives with sustainable healthcare systems. We must do much more, better and cheaper together, including by creating a single market for clinical trials and by taking more decisions at the European level, she said.
Welcome to The Ring.
Thank you.
Welcome. So lovely to have you with us here for this very special edition of The Ring. So the idea here, ladies, is to give our viewers back home a bit of a taste of what exactly you get up to inside that European Parliament chamber, here in Brussels and also in Strasbourg. Sometimes you fire questions at each other, sometimes it gets a little bit heated. Today, as you know, we're focusing on healthcare and the future of it right here in the European Union, and who, of course, should pay. So Tilly, if we can start with you on that very, very pertinent question, who should be paying for the future of healthcare in Europe? Should it be us, the patients? Should it be pharma, the governments, big tech? Who?
Yeah, but if we look what the situation is right now, we see there's a lot of public funding indeed going in research, but there's also the patient that is paying. So you could even say that the patient right now is paying twice. He's paying first with taxes, which go then to funds, and then he pays again a price at the pharmacy. So what we need for sure is at the EU level, but also at national level, more public investment, yeah.
And people are feeling that, especially back home with the cost of living crisis that is squeezing people's purses. Same question to you, Stine Bosse. Who should be paying here? Should it be the patients, taxpayers, or pharma companies?
Well, it actually all connects. And if we don't have strong pharma companies here that can produce, develop, supply us with also the newest of medicines, then we will really lose the faith from our citizens. So it's all connected. And I do agree that there is an issue on how do we look into the future? What is the construction? Is it all everybody has access to healthcare, or is it a different model? That has to be debated. But at the
the end of the day, it all starts and it all ends at the end of the day, that we have a strong and competitive pharmaceutical sector, and then we can discuss who pays.
And that's an important point. Of course, Tilly Metz, if you look at the data, 1 in every 2 medicines, this is back 25 years ago, was invented or discovered right here in Europe. Now it's only 1 in 6. What went wrong?
Exactly. I mean, if we go more to privatization and more leaving all the leadership to the pharma industry, we see that it doesn't work. I mean, that is the conclusion that we can make out of that. So if we look that we have shortage of medicine, that we don't have antibiotics, that sometimes we have. Indeed, we still have innovation in Europe, but we are not really scaling up. But if we look innovation and there is no real added value for the patients, that's something we need to do better. So it's up to public authorities to take back their leadership and their responsibility. I mean, if we go more and more in private healthcare, there is a huge risk of even more commercialization of access to healthcare and of commodifying medicines and healthcare.
Would you agree with that point, Stine Boss?
Yes, I do agree, but I don't think that a strong pharmaceutical sector is the opposite of having a totally sane and fantastic healthcare sector as such. I think these two things go hand in hand. But that is, of course, a question of funding. First of all, importantly enough, funding for the pharmaceutical sector, and then, of course, who pays? Is it tax paid? Is it universal access to treatment and to medicines? Or is it a private sector that we see growing? And there, I think we will have to face that there will be a blend. I am a strong believer in a strong universal healthcare sector that makes sure that there is access for everybody. But you cannot take away, and this is going to be our dilemma, that people travel, people will want the best treatment if they can pay. And here we have some dilemmas and we need to fix them.
Some serious dilemmas. How can you fix this issue of inequality?
No, I think it's key. That's why I think government and public authorities need to play a stronger role in there. I mean, we know that the private sector and the objective of the private sector are not necessarily aligned with what is really the public health need. But I agree, we need a strong pharma sector. We need to have manufacturing back in Europe, and we need to have the conditions, but the incentives for the pharma industry must not rely only on intellectual property rights. There are other models, other alternatives of incentives. For example, the subscription model, or for example, we can have milestones if the pharma industry must give guarantees, and we must have also more transparency and scrutiny from the public sector. There needs to be a better coordination from the public authority in order to make it more equal.
And this issue of scaling up, how can we do better here? I mean, in Europe, we're great at research, we're great in the lab, but getting it to market then is always the big challenge.
Yeah, and there I tend to disagree. So without letting go of the security level for our citizens, we should base much more on our EMA and less on our national entities. Because if you look at it, it is 578 days from the approval of a medicine till it in EMA till it reaches the patient.
And on the European Medicines Agency, we'll come back to that point.
I didn't say that it should not be the European Medicines Agency. I'm very pro-European. On contrary, we need better cooperation between the member states, and that can only be done at European level. I mean, on that I agree with you.
And is the European Union ready for the next big pandemic? Because we know it's coming. I mean, we remember those terrible days of COVID, and we're being warned that the next pandemic is around the corner. Stine Boss, is the EU ready for this?
No. I mean, we are more prepared than we were. I mean, we have learned, and the institutions are also now stronger, and health is a stronger issue. You know, the fact that we now have the health committee, and it's a full committee, and so on. All these things point in the right direction.
That's not reassuring our viewers, just having a committee.
No. I agree. And here I'm back to that we need also a stronger collaboration between countries within the Union. We need links also for ongoing healthcare, not only on the innovation side, but also on the delivery side, also between the hospitals. There's so many things that we can.
To the pharma industry, I mean, that gives a lot of insecurities also regarding the supply chain, regarding the transparency on the real cost on research and development. I mean, I'm not against a strong pharma industry, but we must definitely also consider to have a European infrastructure on research and on production also of medicine. And I think we need to be ambitious there in order not to be too reliant and dependent only on the private sector, where we all agree that they have different objectives, and that is also perfectly okay. I mean, as I say, they are not necessarily aligned with what is really an added value of the medication. That's why there are certain sectors, like the orphan medicines, but also the antibiotics, where the pharma industry is not really interested because it's not really financially interested. So well, the objectives are different, and that's where we need a stronger public leadership of public authorities.
That's the view from Tilly Metz. Let's hear your view there.
You might have recalled that I'm not a socialist, but I do have a lot of social responsibility within the way I think about our citizens. So I cannot see, Tilly, that we should go for a fantastic publicly owned pharmaceutical sector. I think we need a strong, privately owned, privately financed pharmaceutical sector who can see the benefits of staying in Europe, developing in Europe, and delivering in Europe. And you are right in one area. Again, I think it is important that we also agree on areas. I
told you, I promised our viewers we would give you a glimpse of the chamber, and we also, of course, want to hear from you. You can always write to us at thering@euronews.com. But we've covered a lot of ground.
But please let me finish my sentence.
Pause. We'll come back to it.
Okay.
Now it is time for our viewers to get a real taste of Inside the Chamber, when MEPs actually fire questions at each other. So now I'd like you to start with your first question for Tilly Metz.
Well, Tilly, I just want to know, how on earth are you going to make sure that we can be able, from Europe, to deliver the best, the newest medicines, the fastest to our citizens? What is your prescription for that?
I think it's very clear that we need to give incentives to the pharma industry, and on the other hand, to have kind of safe net by a public infrastructure in order to have innovation and to guarantee also accessibility to innovation to everybody. We need to put conditions on this public funding, and we need public authorities to play their role on asking accountability to the pharma industry and on asking transparency on the R&D costs, but also on how they develop their prices. I mean, as I said at the very beginning, it cannot be that the patient pays 2 times or 3 times, once by the data, once by the taxes that he pays, and then again a high price at the pharmacy.
Are you satisfied with that answer, or would you like to follow up?
No, because I still see that there is a high risk with all your good ideas. Some of them we can agree on, but there is a high risk that the pharmaceutical sector would look to other grounds and say, you know, it's much more attractive to us to develop and to invest in the US, for example. So bye-bye. I don't see.
Do you agree with the US system, where indeed the pharma industry wants to put very much higher prices? I mean, that's what they want. That's why they are attracted by the market in the US. Is that the model that we should aim at?
No.
Where only an elite can offer treatment and have innovation access and innovative healthcare? No, I think we must definitely take our responsibility, and that is one of the lessons learned from the pandemic. And that is, Stina, that's what we are working on. The Critical Medicines Act is exactly what we are doing there. We are making that the EU takes more responsibility in coordination what is critical medicine for the citizens, and what is really also of an added value, and how we can bring back manufacturing again back to Europe. That's what we are working on the Critical Medicines
And our
Act.
viewers can read more about that Critical Medicines Act on Euronews.com. But now, Tilly Metz, it is time for you to address your very first question to Stine Boss.
Yeah, but my very first question, I said it already a little bit, is like, do you agree in order to have accessibility and affordability on medicine that we need to have more transparency on cost? And that is meaning when we give public funding to the pharma industry, that we need to put conditions on this public funding. Conditions like supply chain, transparency on cost, etc.
I think first of all, and I will be repeating myself slightly, so bear with me. I think that it's the starting point will be that we have a strong pharmaceutical sector. And you might not agree. You think you jump right into it has to be state-owned and it has to be state-funded. I'm on another page there. Then having said that, then I agree that there are areas, the Critical Medicines Act is a good example, but there are also other areas where we have to think differently as Europeans, but also as countries. And that's why this thing about the nearly 600 days to approval, that we have to get out. We need to make sure that the country's level of approval is not there. It doesn't make any difference. And then on top of that, if we say to ourselves that there's an 80% difference between the countries of the accessibility to medicines, of course that cannot be so. So we have a huge issue at our hands to level this out between countries and to protect our universal health care. But that is only protected if we have earnings. Earnings makes taxes. Taxes makes the money to actually finance healthcare.
I know you had another long list of questions for each other, but we will have to wrap it there because we've now heard from our MEPs, and I would really like to bring in another voice here. I would like to bring in the voice now of the head of AstraZeneca, the CEO and executive director, that's Pascal Soriot. He recently said that the pharma industry in Europe will be reduced to just a shadow in 15 years. He said that this was due to two major threats facing the pharma industry. One, pharma companies are investing heavily in the US to avoid heavy taxes by the Trump administration. And of course, the other elephant in the room, China is of course the leader in generics and a major competitor when it comes to innovation medicines. So Tilly Metz, I'm curious to hear your view here on the concerns of the industry and of the CEO there of AstraZeneca.
No, I mean, first of all, what I want to correct, because it seems like I want 100% only state-owned pharma industry. That is wrong. I just want a safe net that is public in order to guarantee that we are not 100% lying. But the pharma industry has an important role to play. And I spoke about incentives. I'm just convinced, and we see it in the reality, if we are pragmatic, we see in the reality leaving it all to the pharma industry that the system doesn't work because we have shortage of medicine, etc. What I said before. But we need other incentives like the subscription model, where you know if you work on research, for example on antibiotics, that you get the fixed amount of money in order to work on that. That is one model, or a milestone model. So,
and Stine Boss, if I can just bring you in here, I mean, is it scaremongering what he says there, or would you agree with it? Because I mean,
no, I agree
still
with
the home to big pharma.
And I think it's actually more serious than we can dream of. We are, and this is a little bit dramatic, but it's good on television. We are under attack. I mean, our pharmaceutical sector is under attack. This idea of the nation, most favored nation legislation that the administration in the US put in place is really, really hammering us. And I'm not saying that we should give up, and I agree with you on the fact that there should be a basis coverage, obviously, for citizens in Europe, also regarding the safety of the approvals. But we have to understand that we must fight this with giving terms and conditions to our pharmaceutical sector that can compete with this, in my opinion, very mean model, and that we have to fight back.
Would you agree with this, what she calls a very dramatic statement?
Let's look what is at the center of our concerns. And I am allowing myself to say that it is different as a politician than from the pharma industry perspective. At the center of our concern is the patient. If you look at the situation of the patients in the United States, they are in a much worse health situation. If you look mental health, if you look obesity, if you look at a lot of diseases, suicide, everything, they are in a much worse case. What do I have from innovation if it's not accessible for the large public? And in innovation, we are not bad in Europe. It's in scaling up, it's in manufacturing where we are leaking.
And we have a very fragmented market as well, Signe Bosse.
Sure, we have this fragmented market, and we have really not a capitals union, right? So we need also the fact that investors should have investors and companies much easier access to capital to make them stay here. We also have to face, Tilly, that no matter how we turn this around, there needs to be a strong sector here. We need to understand what the problems is for the sector, try and solve them, and then of course fight back to the US, because I agree, even longevity is much better in Europe, and we should not give up on these areas, but it's not on the contrary to have a strong sector. And then it comes back to the first question, who is paying? And there I think there is a need for a truly and deep discussion on transparency, on how do we actually fund, because our model is like 80% gets everything, right? We covered a lot of people. That's why we buy a lot of pharmaceutical products at a cheap price. In the US, not a lot of people are covered, so they pay much more per pill, per thing. So that makes it completely uncomparable. And that we have to sit down and really investigate and find out, also in the Biotech Act, how are we going to solve this?
So you have a lot to do, ladies, but now it is time, in fact, for our next round. Now I'd like to bring in some figures. Signe Bosse alluded to them slightly earlier, but I want to make them clear for you. There is a big problem when it comes to Europeans having to wait for new medicines. The EU average is about 578 days. That's from approval to patient access. And it varies from country to country. Yeah. Patients in some countries have to wait 7 times longer than others. While the fastest is in Germany at 128 days, Portuguese patients wait the longest. And then we have a big problem, and that's, of course, the European Medicines Agency is authorising centrally these drugs, but of course, each country then is deciding when to reimburse. So your reaction here to this inequality?
Yeah, this is completely how it is, but of course there is an explanation. It's not because Portugal wants to have a longer period and a less good access for the population. It's about finances. It's about, can they afford it? And here we are, of course, entering into very, very difficult discussions, because a country like Denmark, if you compare us to Bulgaria, to Romania, then we are in for big, there's a big difference. And that we need to, over time, solve, but one of the ways to do it is to, again, what we can make better and cheaper together we must, including the EMA, to save all the money in all the countries.
And the irony is, in Germany, 128 days, that's supposed to be quick. I mean, that's a matter of life and death if you have to wait that long for your pills.
Yes.
Yeah, indeed. And what we need also is we need more cooperation in European procurement, so that we buy together, in order also with strict timeline and also with the security on the supply chain. So that's, again, we need to give more incentives, that is true, but that goes hands in hand with conditions of supply chain, etc. And we need, of course, on that I agree with Signe Bosse, we need also to give the EMA, the European Medicines Agency, more human resources and more resources in general in order to be more efficient, and then that we need less and less also there to rely on national issues.
And should there be an EU-wide pricing for essential medicines?
I think at the end of the day we will get into that area. I don't see that we can avoid having some kind of, more transparency and more central discussed pricing.
Because now when you go to your doctor, sometimes they say, go to France, you can get
Yeah. That's why I say, but I had this conversation with, you can probably guess who it is, but it was a CEO of a large Danish pharmaceutical company. And I said to him, I don't worry when I go in a shop and I buy, like say H&M, and I buy something, and I can see the price in Sweden, in Germany, in France, and I'm still happy paying with my, unfortunately, it's still Danish kroner. So I think we should be more transparent, we should be more bold together with the industry, and they are also, at least some of them, maturing in that direction, of course also because of the big threat that we have just debated from the outside. But having complete transparency, I'm afraid that is probably going to be some years down the road.
Now, I'm perceived that we definitely need to put public interest is definitely more important, especially in the health sector, than commercial interest. I mean, at the very end, the very famous company, pharma industry that produced drugs, in the last moment, the price was really increasing again. Why? All the research, all the R&D was done, so we need definitely transparency. And as I said, that goes hand in hand with also public funding. It's something we owe to the taxpayers, we owe to the citizens to ask for this transparency. And especially when we speak of a fundamental right, which is access to health care.
Because as you said, twice or 3 times or 4 times already here in the programme, consumers are paying twice, patients are paying twice. This is a big problem.
Well, I'm not sure I agree completely on the fact that people are paying twice. I agree that there is a debate on how can we make this more transparent, how can we lower the differences between the countries. But to be honest, I mean, the pharmaceutical sector invests a lot, and they should. And I also agree that in some areas they should also be held accountable. If there is public money involved, yes, I agree on that.
Shall we speak about the benefits that they made with the COVID-19?
Yes, but look, then on the other hand, of course there is large number of workplaces, innovation, attracting skilled people, and all this is also beneficial for Europe. It's not only it's not a non-sum spill thing. We have to look at the total, and I think it would be devastating if we lost the last industry, ladies and gentlemen, the last industry where we are still close to, not even, but close to on par with the US and China. We lost digital industry. So do we want in 10 years from now to have a pharmaceutical sector where we say that's history, it's gone?
And on the digital industry, that's of course for another episode of The Ring. We'll have to wrap it up there because I would love to move on to the 5th and very last round of this very special edition of The Ring, which is focusing on the future of healthcare. Ladies, are you ready?
Yeah.
Excellent, because you need all your wits about you for this last segment, because it's a little bit different. You only are allowed to answer using yes or no. Does that sound good?
That sounds good.
Great, let's do it. Stine Boss, let's begin with you. Should the EU cap prices for essential medicines, yes or no?
Can I have a yes, but?
Very briefly.
Yes, but it has to be limited to very, very special situations and very special medicines.
Okay, let's see if you can do a yes or no here.
The same question, yes. It's a fundamental right. Okay. Access to fundamental medicines is a fundamental right. And
another question coming for you both. Tilly, I will start with you. Should Brussels negotiate drug prices for all EU member states?
I think that would be a strength if we do that. We saw at the COVID-19 that negotiating together gives us more power. So yes.
So that's a yes. What about you, yes or no on this one?
Down the road, it will be a yes from me also.
Should patents be waived during major health crises?
When you say waived, is that supported, helped?
Yeah.
Yeah, of course. I mean, the patients, and this is...
You say yes, Dinner?
I say yes to the fact that we're politicians, we need to keep our main focus on the patients. No doubt about that.
And now a question you're both going to love. Should medicines be the same price all across the European Union?
That's a long way to go there, but that would be coherent if we listen to the European citizens that want more healthcare and also
So that's a big yes, a resounding yes. What about you?
I mean, it goes hand in hand with what I just answered. So if you have a procurement way down the road that is common European, then of course you also have a transparent common pricing.
And just finally, is the future of EU health and innovation bright?
Yes. I'm a strong believer in the EU as such, and of course also in this sector, but we have to get a lot of our act together.
And what about you, yes or no? Bright future or not? Yes or no?
Bright future, yes, well, because we should listen to the citizens and we should put more funding and not cut the funding.
Telemans, did you agree with anything you've heard?
Sorry?
Did you agree with anything you've heard from Stine Bosch today?
Yes, she said that we should waiver the intellectual property rights during a pandemic.
There you go. You see, it's here on the ring where we get people to talk, disagree, and sometimes agree. Thank you so much, and a round of applause for our two MEPs on the ring, Stine Bosch and Tilly Metz.
Thank you.
And thank you so much for tuning in. As always, we love to hear from you. Write to us at thering@euronews.com and stay with us here on Euronews.
Thank you, sorry for having a bit too long sometimes. Thank you.
Thank you so much to our two contenders, and thank you also to Maeve McMahon. And remember, if you like that taste of the ring, you can catch more episodes on Euronews and on euronews.com. Now it's time to move on, and for the next panel, we will be honing in on a very specific issue that affects millions worldwide, hundreds of thousands here in Europe, but which is arguably not given the attention it deserves in EU policy debates. I'm talking about rare kidney diseases. Now, we know that almost 800 million people worldwide have a chronic kidney disease. Rare kidney diseases form about 5% of those chronic kidney diseases. But these rare diseases often begin in childhood or in early adulthood, and they have a disproportionate impact compared to other chronic kidney diseases. Now, we have a unique opportunity today to shine a light on this very issue. I will be joined now by a range of guests that represent policy, industry, patients, and clinicians. So let's welcome them, and I will take a seat here. We have Lydia Abad-Frank, who is Chief Medical Officer at Sobi. Welcome. We also have Daniel Gallego, who is President of the European Kidney Patients Federation. Welcome, Daniel. Professor Michel Jadoul, who is Emeritus Professor of Medicine at the University of Louvain, and is also co-president of the European Kidney Health Alliance. And we have member of the European Parliament, Nikos Papandreou, who sits on the European Parliament's Health Committee.
Hello.
Welcome to all of you. It's great to have you with us here at the Euronews Health Summit. As I mentioned there, rare kidney diseases. I'm going to come straight to you, Daniel, because I know you have lived experience of a rare kidney disease. Tell us about that, and tell us about how that experience is shaping the work you do as a patient advocate.
No, thanks you very much for the kind invitation to Euronews and the support of Sobi. Of course, I'm trying to share with you the lived experience and the impact of socioeconomic impact, the burden of chronic kidney diseases, and especially as myself, rare kidney diseases. You maybe probably you are hearing about rare and you are thinking that this is something that happens to others, but this is not the case. It's a million of people suffering of rare kidney conditions, as myself. And you can imagine in a childhood or when you are an adolescent, I was 20 years old and split my life in two. I was not ready. We are not ready. The healthcare system is not ready because chronicity is not easy to manage. And the impact is so high. To depend on a machine to survive, as dialysis, you can imagine how is the burden. So the problem is not only the invoice, the economic invoice of kidney replacement therapies such as dialysis and kidney transplantation. The problem is the impact in the emotional and socioeconomic. The major part of the dialysis patients are not working because it's impossible to conciliate work and life. Life participation, health related with quality of life, daily life activities, and especially I don't want to forget caregivers and family, because this is the rare kidney diseases are affecting not only the people with the condition, are affecting the mothers, the parents, and the family members. And I think we need, with the findings of SOBI, with this barometer we are working, we have shown that we need the support not only from the healthcare system, but also the multidisciplinary care. Another important thing is the challenges in diagnose, and not only the challenges in diagnose, but also the how is the delay this diagnose is not giving the chance to preserve kidney function. We are trying to have a fulfilling life, because at the end we are not only kidney patients, we are only kidney patients during the treatments or during the appointments. The rest of the time we are people living with the kidney condition. And this delay on the diagnose, even me, myself, I had 2 biopsies to obtain the right diagnose. And that delayed diagnosis is not giving the chance for a quality of life and to preserve the kidney function. And of course, it's not only about mortality or survival, we are talking about quality of life. And these challenges is always an opportunity. And I think you have heard the news, and this is the right place to say the Euronews, but the truth is that the most important thing happens out of the hospital, out of the healthcare system, happens at home. And we need to tackle this in a holistic way. And the last point I think is important to share with you is that when you have a kidney rare condition, you are in a car and you are not the driver. The healthcare system is driving you all the appointments, all the tests, all the things to find the right diagnose. And I think we need to, we deserve a dignity and hope for the future, and to give them all the resources to manage the chronic kidney conditions in the right way, not only with the tools of the healthcare system.
You did mention the SOBI barometer. We will come back to that in just a little bit, because I know that SOBI's been doing work to measure the kind of human and socio-economic cost of these diseases. But I'd like to first bring in a nephrology expert here, Professor Shadul. Daniel also mentioned the critical importance of early diagnosis. He also mentioned the nature of kidney replacement therapies, dialysis and transplant. So why is early diagnosis so critical, and what can be done to boost early diagnosis?
Well, thanks for the question. It's a very important one. I'm struggling with the best answer, or at least for my patients, for decades. But in a nutshell, many kidney diseases are silent for a long period of time. So unless there is something pointing to the fact that there may be a kidney problem, the diagnosis may be missed for a long period of time. But the good news is that the kidney speaks in one way with the urine. And so here, really, urine testing is cheap, no need for a needle, like a blood test. So it's really inexpensive. It's easy to perform. Anybody can collect a few milliliters of urine, and then it's sent to the laboratory or even in the office of the primary care doctor with a dipstick, and we can have a clue that there is something wrong. And if there is something wrong, then the question is the healthcare system, how you escalate from primary care doctor, which is kidney disease are usually perceived as complex, which is maybe true. My wife is a primary care doctor. Of course, she has had some contact with me over the years, so she knows probably more about kidney disease than most primary care doctors. That being said, they are perceived as complex. But that's up to the various countries in the EU to think about the healthcare, how best to promote. integration, quality, and so in order to make that most efficient and that the right patient is met by the right physician. That's we can discuss.
We'll get back to that because it sounds that there are quite accessible, cheap solutions to boost early diagnosis. But I'd like to come to you, Lydia Abad-Frank, who is the Chief Medical Officer at SOBI, of course. On delayed diagnosis, what are the costs, according to the research that you've done, also for the patient emotionally and also socioeconomically?
Yeah, thank you. Thank you for having us here today and really bringing up this study that we have done in conjunction with the community, so researcher, patients, and it's really a study to assess how healthcare providers, how patients and obviously caregivers are having this socioeconomic and burden, emotional impact on their daily lives. And what we see is that it's critical and it's urgent to have this early diagnosis because especially today we have targeted therapies that will potentially delay this progression to kidney failure and to dialysis and transplant. So basically alleviating that health economic and emotional burden that Daniel was referring to. So we have data that has been collected across more than 70 patients and more than 30 healthcare providers across different countries with different standards of care. And we see that it's really very systematic that patients get delays in the diagnosis that sometimes is up to 5 years, but 1/3 of the patients is more than 3 years, because those symptoms that Professor Jadul was mentioning are very inspecific, and then patients end up in a state of really disease that it's so advanced that only dialysis or transplant. And I think that it was 1 in every 3 patients had been already on dialysis at the time of diagnosis, and 1 on every 4 patients already had a transplant at the moment of diagnosis. And obviously, that is not acceptable if we compare other silent diseases like hypertension or high blood pressure or diabetes compared to kidney diseases. This is something that we need to address now, and we have the data and we have the tools to have really an early intervention with targeted therapies that can prevent this progression.
Let me bring in MEP Nikos Papandreou to the conversation. Welcome. From a policy point of view, what can be done? What are your ideas in terms of tackling some of the challenges we've just heard about?
Thank you very much for the opportunity to talk. Always glad to have a patient. I think it's very important that we include patient groups in our discussions. And in some countries they're actually institutionalized in terms of the health system. Like I was on Cyprus recently. I was very happy to see that. So they're part of the process. In general, the EU has turned to health recently. I mean, the cancer plan started in 2019. So the fact that we're here today is already a step ahead. And now we have a health committee, which I'm on. For what we're trying to do now, all of us on the committee, is to make sure there's funding, generally for health. For rare diseases, we're trying to be very active in that in general before we get to the specific. And our group, S&D, has proposed a rare disease action plan, which we hope it then turns into money. The chances of getting money for each rare disease is rare, difficult, but for the overall, yes, we might be able to do that. Now for this, what we need now as deputies is the expertise from the doctors and the patient. It's clear that early screening is there. Some are very cheap, blood test. Urine is maybe more difficult for high-risk patients. My dream is to have a panel of tests that would include many diseases, many things that the citizen could go through. It's not clear how we do that, but the ones that don't cost so much for high-risk patients like diabetes, the chances are they don't get a kidney test, from my understanding. That could be included. So there's things that we can do in terms of policy proposals from the EU to support this effort. And of course, research in the end, that's a big question. Hopefully there'll be a solution for these rare diseases. This is not so rare, this 1 million, because the rare diseases we're talking about are 6 people in Europe. So that's even more difficult. And just a final point, from a political point of view, is how do you convince, this is our job, the health minister to put money in a rare disease, because it's rare, it doesn't get votes, let's be cynical. But besides that it'll cost more in the future, that argument doesn't work too well for the health minister, they have to spend now. There's breakthroughs from research on from rare diseases that end up with the general population, and that's a very important point. Like the statin pills came from high cholesterol patients that rare diseases. So you can make a political argument for focusing on rare diseases, even though it might be 6 people. And that's why you need the political side to convince finance minister, health minister, EU council, put money here.
Very interesting. I'll come back to you, Professor Shadul. I'm sure you're eager to respond to that. But I was going to bring up also, because we don't know there are links in terms of the kind of this early symptoms when it comes to cardiovascular diseases as well as chronic kidney diseases. So the Commissioner said earlier that cardiovascular disease, leading cause of death in Europe. There's a lot of initiatives, a lot of funding. Can that be leveraged as well to help these patients?
Yeah, so I really wanted to follow up on what you said about the cancer plan and now the Safe Hearts plan that is, has been, at least the first version has been released, and there will be discussion in the parliament and so on. So clearly there is overwhelming scientific evidence that kidney disease in the context of so-called cardiorenal metabolic with diabetes and or obesity and or hypertension or cardiovascular disease, kidney disease is a multiplier of the risk by a factor 5 or 10. So it's really dramatic. And that is true for both reduced kidney function and albuminuria testing, so urine testing. So in other words, if you don't have the urine test, you miss part of the risk. And so to turn back to the Safe Hearts plan, the European Society of Cardiology and a number of other organizations, obesity people, diabetes, and the kidney, the ECA and the European Renal Association. We had a task force launched some weeks ago, and that was published on the ESC website, a task force to discuss which are the so-called CRM cardiorenal metabolic, rather than purely cardiovascular health check, but cardiorenal metabolic health checks. What is the panel of tests that should be done? And it was an easy discussion. There was agreement rapidly that 8 tests, and those 8 tests include 2 for the kidney, urine, albuminuria, and GFR, so function of the kidney with a blood test. So really, urine testing, if I may again repeat myself, is grossly underused. In Europe and elsewhere, 50% of those with diabetes, there are guidelines for 2 decades, saying that anyone with diabetes should have a urine test once a year. 50% of the subjects have a urine test. So we can do better. And anything that the Safe Hearts plan can do to point to albuminuria and kidney tests will improve awareness across Europe and will motivate the member states to do better in that respect.
And I'm sure in this case, as we've heard many times today, there are cases of inconsistencies across European member states as well. Maybe we can come back to that. But Daniel, I'm going to come back to you because the purpose of all of this, of course, these initiatives would be to avoid kidney failure. Give us, again, a bit of a sense of why that is so important.
Yeah, of course, I think, well, in our opinion, and I think the healthcare system is agree with that, is that the best dialysis is don't need dialysis, no? And the best kidney replacement therapy is don't need kidney replacement therapy. So this is because the early intervention and early diagnosis give a chance to preserve kidney function and avoid as much as possible, and because as you can imagine, to depend on a machine to survive and to undergo the dialysis treatments, it is tough. It is so hard, not only for the lifestyle limitations. You have a lot of restrictions of diet and nutrition and even fluids. We cannot even drink water. As you can imagine, in a society that celebrates everything by eating and drinking around the table, at a birthday, a wedding, it means a lot, no? So I think we are now embarking in a new era of kidney medicine and nephrology, and we are now in the position to new therapeutical options and early intervention to delay as much as possible and avoid what I'm suffering for more than 30 years on dialysis, and I can't imagine a world without dialysis in the future, avoiding not only the invoice but also the suffering of people undergoing the treatment, mentally, social, and economic. And of course, I think we deserve this for giving this dignity for people in the future that don't dialysis zero maybe in 10, 40 years, I don't know, but this is the goal.
Lydia, what else can be done from a medical or clinical practice point of view? Do we need new guidelines, for example?
Yeah, thank you very much. So I think that across all the therapeutic areas, there are clinical guidelines that are updated regularly. But I think that we always need to really, we have the obligation to ensure that new treatments that are made available because of science data is generated and regulators have approved those products, that those updates are translated into the guidelines, because that means that then patients will be able to have access to those treatments. So I think that we need to look at other therapeutic areas. I think oncology in the US, I think it's a great example. So the NCCN guidelines are updated in 2 ways every year. They have one mandatory update on a yearly basis, that it's a schedule, and then they update the 88 oncology guidelines on a regular basis. But then they had ad interim, like ad hoc meetings, if in between updates of the clinical guidelines, FDA approves one product based on the evidence that has been generated. So I think that obviously updating guidelines, it's a lot of effort for the community, but I think we need to learn how to do that in a faster way so that then the science it's translated in an approval and then into access to patients in a shorter period of time.
Okay. MEP Papandreou, you made a very interesting political case for tackling this challenge earlier, saying, you know, by doing this, there can be benefits, financial benefits. It really does benefit the entire system. But we do know that we have an aging population in Europe. Healthcare systems are coming under increasing pressure. Several countries are really facing a dire situation. Doesn't that mean that this is becoming all the more challenging for rare diseases, especially?
Yeah, the demographic is certainly going to be a big pressure on the system. My long-term solution is immigration, but that's very radical for Europe, because we're not going to change our sex habits, put it like that, at this age. And even the richer country, in Greece, they keep saying to subsidize children. Norway's very rich, they have the same problem. I mean, everybody subsidized there, so it's not a matter of financial things. So the demography is going to put pressure. We have Alzheimer's, we have all those diseases. Now, what I had a question that maybe you can answer medically. If we do the urine test early, do we avoid the problem? And wait, before, who should we do it on? Everybody, like a child of 8? Or do we see people already have a, because if that's the case, it makes the policy prescription easier for me, that we should only do people of 20. Now we have the people who lived it and the experts. So that would be, sorry to intervene in.
No, please do.
I'm happy
because I need to think of this particular
provide my answer, but the answer is the answer of the task force appointed by the European Alliance for Cardiovascular Health, including the kidney organizations. And we had a consensus. And the document, happy to send it, but it's on the ESC website, says something like this. Between the age of 35 and 65, every 5 years, there should be a systematic CRM, cardiorenal metabolic health check, that includes 2 kidney tests, and it's not because it's to make everybody happy, it's just because there is overwhelming scientific evidence. 2 kidney, 2 diabetes tests, glucose and HbA1c, body mass index, and another parameter of where the fat is in the body, blood pressure and lipids. 8 parameters, so nothing very expensive or extreme. Between 35 and 65, every 5 years. Before 35, at least once. That does not preclude more. And there are opportunities, let's say opportunistic screening for ladies at the time of planning pregnancy or at the time of the last vaccination in adolescents. So there are a number of potential opportunities. And after 65, the advice is more every 3 years than 5 years, because we are all a bit older, and so diseases are. Now, to turn back to the let's say, the cost effectiveness, which is, of course, a very important question, which is implicit in what you said. I've been a co-author of a paper looking at that across all Western countries, Europe, US, even Middle East, high-income countries, and so there is no doubt that for common diseases, it's cost effective. There are some drugs like SGLT2 inhibitors, just to name one, recent, very cheap, a few euros a day, that will, for common diseases like diabetic kidney disease and others, will delay by years, sometimes decades, and delaying by decades means that for a number of people, they will die for something else without ever being on dialysis, which saves a lot of money. So the cost effectiveness, I think there is no doubt, it's there.
But in the absence of a mandatory screening system, what about communication and making people aware of this? We mentioned it's a silent killer in many cases, or a silent disease. But what about making people aware? Is there room also for more outward communication so people are really aware about the nature of these diseases?
No, absolutely. Of course, everyone knows about sugar or cholesterol. We need to include in the care conversations in the general population the creatinine and the glomerular filtration, because you need to be aware. It's like you're born with a battery and 100% is the kidney, but you don't know the battery maybe until it's too late. And always the diagnosis of chronic kidney disease or rare kidney diseases are too late. So we are reaching too late the high-risk groups. So we need to change that, no? And of course, it's a question of awareness and about early intervention, education, and global campaigns. And we need to work together. I think we are an unbeatable team. We have the administration with the capabilities, we have the evidence with the scientific, we have the research of the pharmaceutical industry, and we have the lived experience of the patient. So together we can do it.
What are the major barriers, though? Because we have a great team here, and we are all agreed that this is an important issue, but it seems that there are barriers as well to implementing these solutions.
Yeah. So first, maybe before going to the barriers, I would like to always trying to look at the world as a whole, and because when we hear about these screening campaigns and the cost efficiency and how difficult it's to implement, there are countries that have this mandatory screening test for not only cardiometabolic but also renal, like Japan. So this is something that it's already existing in other countries, and they have proven that it's feasible. But obviously there are barriers. We've been talking about the awareness. I think that one of the other main barriers is when we design clinical trials, we need to provide evidence, clinical evidence that the product, it works, that it's meaningful for patients, so that the outcomes of that research, it's meaningful for patients, but we need also to satisfy the payers. So sometimes we have this discrepancy between the requirements of payers that want hard and endpoints like mortality or transplant avoidance that can take decades to produce that data, versus regulators that it's very good to see that there is already a shift in the mentality, and regulators across the globe, not only in Europe, they are accepting surrogate markers, meaning data that what it's reflecting is the renal function and not only the late stage failure of the kidney. So I think this collaboration between regulators, policymakers, regulatory agencies, payers, and then the community together with the industry, it's critical to avoid those barriers, because then we can bring faster the products to the regulators and then decrease the time between the approval and when patients have access.
We heard the interesting example there of Japan, so that this is happening in other countries of the world. In Europe, maybe MEP Papandreou, you can come in here. This seems really feasible. Why isn't it happening yet, you think?
Well, we don't have the health system doesn't necessarily take orders from the EU. Each country makes its own decisions, especially on the pricing, and that's a very complicated thing. So, but we could set up standards. And one thing that you mentioned about not having a center, we have the ECDC, communicable diseases. How about NCDC? To have a center to propose for this, I think that one's not so hard to do. It's not hard to set up a new bureaucracy in Europe.
Because they're projected to skyrocket.
But that one's something that would give the center the research. So that would be very important. I really believe in bringing these tests to the people. So I did something called, I did on the liver in Piraeus, lower class area of Greece, poor people, a free fibroscan test, which is fatty liver test. It was voluntary, of course, so it wasn't like a statistical thing. About 300 people, of which 40% had serious problems, and they were all recommended to go to expertise. But then I wasn't a doctor. We weren't doing a study. I didn't follow their tests. So for me, the urine test is important, and then the part 2. So, and also what, I forget your first name.
Daniel.
Daniel, what you said about the patient journey, as they say, that's an interesting word. In rare diseases, I don't know, you know better if there's protocols. You see this doctor, that doctor, if there's such a thing. So you don't go crazy trying to figure out your disease, who to see, who to call, what's your best friend. I think there's not enough information. That is something that the EU can easily provide. So there's lots of room for us here. As I say, the good news is we're on it. We started a little late, but I think that Europe itself is going to try to emphasize health more. My other concern is the things that lead to initial kidney problems, and that's our lifestyle, I think. And so when you talk about aging population, our lifestyle, which New Zealand has a Ministry of Healthy Aging, I think it's called. Very nice idea. And also retirement age, there's no retirement age if you don't want to retire. Healthy aging. I'm just saying there's ways for demography to take care of itself. In the special case, I'm hoping for the day where the dialysis machine would be like your cell phone. You know, I'm just guessing in the future how that would be.
Professor Zadel, your response, I saw you.
No, yeah, I just would like to follow up on what you said about the standard, putting a standard. And I just want to follow up on one point. It's that, indeed, I think the wording of putting a standard is very important. And in that respect, what we learn from the literature in other fields is that if there is a mention of screening or systematic health check, those who would benefit most, because they are less favored culturally, socioeconomically, so we know statistically their health will be somewhat less good, are those most likely to miss the test. So we should find, policymakers should think about how best to make it really systematic, because there will be more benefit from those systematic tests. And I'm not a policymaker, I'm happy to be a doctor. That's a key comment I wanted to make.
And a challenge for you there.
Yeah.
We've touched very briefly on financing. You know, how is the situation in terms of investments and the right attention on this issue?
So I think that if we look at rare diseases in general, I think we need to be, I always like to look at the bright side of life. So I think if we look at how rare kidney diseases have increased the clinical research over the last decade, it has increased more than 123%. This means that we are getting the right attention to rare kidney diseases. If we step a little bit back, but we focus on EMA and in Europe, last year in 2025, EMA approved 46 novel drugs and 41% for orphan conditions. So obviously, what we see is that with the increase in innovation, there is more attention to rare kidney diseases and to rare diseases in general, because we are able to diagnose better with genetic testing. So we are able to diagnose better, identify what is the mechanism that drives the disease, and what is more important, to develop target therapies for those conditions. So I think we are moving in the right direction. Obviously, there is still a lot of room for improvement, but I think it's good to see how things are getting to a stage of approval.
Daniel, you also represent a patients' federation. Tell us a little bit about your work. Is your voices as patients being heard here?
Yeah, of course. I think as a kidney people having a condition, I think the most important thing is three things. No, in the debate with the policymakers and here in Brussels, I think one is voice. We need recognition, we need awareness, we need to be heard. No? The second is choice. We need access to the treatments, the early diagnose, all the innovation, research to better diagnose and delay as much as possible. And the third thing is co-production, no? Co-produce the strategies, protocols, everything together. Because I think we are learning every day by day, and it's not the same to know the path than to walk the path. When you walk the path, you learn everything about the rare kidney conditions or about the chronicity, and you learn how to deal with. And I think it's important, these three things together in the debate, to improve, of course, this new kidney medicine, to arrive early for better outcomes and better endpoints.
We are nearing towards the end of our debate, but I do want to come back to all of you, and maybe just to kind of close off as well. I will start with you, MEP Papandreou. You've spoken about making the political case for this to be tackled head on. What do you take away from the panel and from what the rest of your panelists have said?
I know you're in a difficult place. I'm optimistic that, as you said, the team we have here, we're going to do good things, and we're trying to do good things. The Health Committee has many champions for different issues, and you can consider me as one of the efforts on the rare diseases that I have to say I reacted to being involved, because we have to think of, are we helping the general population? But I have now the good arguments to say we have to really focus on rare disease, because it's such a special case and people are in such pain. And I think the EU is making the shift, at least the community in Brussels. And these sort of meetings that you're doing for me are very helpful. They give us information, and of course we follow up with how we can shape policy. And one small thing that we're doing with rare diseases is to make cross-border clinical trials easier, because rare disease means that we need to find a larger pool of people and to include women, the gender gap. So we're trying to focus on many rare diseases. It depends on the researcher's interest to find the funding. And as you maybe heard before in the previous discussion with the Critical Medicines Act, that there's great access to new therapies across Europe, from Cyprus to Malta to Spain, that everybody has equal access.
Okay, I'll come to you now, Professor Sadoul. Maybe your closing remarks.
Yeah, well, my closing remarks, not surprisingly, will be about urine testing. We have made substantial progress. I mean, to turn back to what you said, I mean, the last 7 or 8 years, I've seen more new drugs in the field of nephrology than in the prior 30 years. I'm now a kidney doctor for 38 years. And that's partly because now the reduction of albuminuria is one of the endpoints in a clinical trial. So we are progressing, but still urine testing is underused. And I think the Safe Hearts plan is a wonderful opportunity to make sure that across Europe, people become more aware, policymakers and others and nation states become aware that urine testing can be used much more. It's cheap, non-invasive, so there is every reason to use it. And then to escalate healthcare from primary care to specialist to super specialist for very rare disease, where sometimes an academic hospital may provide the best care, but that's another story. Yeah, thank you.
Okay, Daniel, your closing remarks?
No, I think it's time to take action. I think it's the right time now, because we have the challenge and the opportunity at the same time to tackle rare kidney diseases in a proper way, not only for all the clinical aspects, but also for the humanistic and the psychosocial support. I think we need multidisciplinary care, and this means not only for clinical outcomes. I mean more about quality of life, about how we are living and how we are dealing with, and we need support, psychologists, social workers, nutritionists. We need to tackle trying to reach the high-risk groups, and not only the high-risk group, but also general population at the beginning. And I think this is a matter that maybe is a long-term way, but we need to act now to start to see the results in a medium or long term.
And you mentioned, of course, we haven't had time to really talk about the impact on families, clinicians. Obviously, there's a big landscape here. Maybe the last word to you, Lydia Abad-Franco of SOBI, your closing remarks.
So I think for me, again, being in really positive about the new era that we are seeing in the rare kidney disease space, I think what it's really important is that we understand that there is an urgency to diagnose patients, because with that, we can have the urgency to treat with targeted therapies that can delay disease progression. And that means that patients will keep their kidney function for as long as possible, delaying dialysis and kidney transplantation, which is in the end what is the huge burden for patients and the caregivers. So I think that we need to be excited about the new era, but we also need to work together to make this happen and to make this a reality.
Okay, and maybe the barometer you have mentioned, but some of the key findings of that you'll be working on.
So this is the rare kidney disease barometer. So what we are being talking about with all this data from patients and caregivers. And I think that here, what we hear from patients is that the delay of the diagnosis has had an important impact. And there is a lot of information on what are the consequences of having to go through dialysis and through transplantation, meaning that patients have to spend 3 days per week, 4 hours per session at the dialysis clinic. With that, patients cannot afford having a stable life, meaning attendance to school and to work. It's almost impossible. And that it's linked to emotional also burden. So I think it really impacts not only the patients. Imagine a child having this disease. One of the parents cannot work, needs to give up everything to take care of the children, but also the other way around. If the child is having to go through dialysis, because these diseases affect also patients in very early ages, and if the children cannot go to school, cannot go to social parties with all the others, and one of the parents need to stay at home. So it's really affecting the whole family, the whole environment, and it's really a huge impact on the economic side for the family, on the personal fact of the personal evolution, and really with that, I think also we see a lot of high anxiety, depression, guilt as well. And also when the transplant can fail, up to 30% of the transplants have relapses, and then they need to go through again another transplant. That creates a lot of anxiety and also guilt in these patients. So it's really a whole picture that we are trying to understand.
Very briefly, we have a few seconds.
Just to stress that the cost-effectiveness analysis of detection early of kidney disease does not even though it's cost-effective, does not take into account that hidden burden, which is within the family, and the consequences are not taken into account in that cost-effectiveness.
Well, thank you so much to our team, one team of panelists today, for shining a light on this very important issue. And I should say thank you also to our partner, Sobi, for making this panel possible. Thank you for your support.
Thanks to you.
Thank you.
Thank you. Merci. Thank you very much to our panelists. I'll invite you to leave the stage because we do have one panel left. We have 2 sessions, 1 panel left. Our next panel will be focusing on something a little bit different. It's called Mind the Gap. Should the EU have a greater health mandate? Like, as we've heard throughout the event today, we know that health is a national competence, but recent crises have, of course, raised the question of whether the European Union should be playing a bigger role in health policy. So what should the balance be between national responsibility and European coordination? To anchor our next panel, I'm happy to invite our EU correspondent, Maya de la Baume, to the stage.
Thank you, Marit. Thank you so much. So, Marit, as you said, the EU treaties are very clear. Health policy is primarily a national competence. The EU can support, it can coordinate, we've seen it in debate, it can complement national health system, but it cannot harmonize them. Yet the COVID-19 pandemic has challenged that framework. We've seen it again in all of the panels that you have witnessed. The EU launched the largest coordination vaccination campaign with the COVID-19. And in 2023, European Commission President Ursula von der Leyen declared that Europe had become a true health union. European health union. Still, the debate continues about whether the EU should go further. So tonight, we ask, should Europe have a stronger health mandate? And to discuss these fundamental issues, we welcome on stage our very first guest, Peter Agius, MEP from the European People's Party. Welcome on stage, Peter. We also have Mika Sokolovic, who is the Director General of the European Public Health Alliance. Welcome on stage, Mirka. For the government perspective, we have Sven Henkusen, Deputy State Secretary, on Health for Latvia. Welcome on stage. Another MEP from the Socialist and Democratic Party, Vytenis Andriukaitis, who is an MEP but has been the Health Commissioner under Juncker in the last Commission. And welcome to this stage. And our last guest is Matthias Wismar, Program Manager at the European Observatory of Health System and Policy. Welcome, Matthias. So maybe let's start with Mr. Andriukaitis, who has been, Health Commissioner in a previous mandate. Let's start with you because it's very interesting to have maybe the historical perspective on things. Since your time at the Commission, would you say, or would you consider that the EU has gained unprecedented powers when it comes to health? And what are these?
Frankly speaking, your question is a very important one. May you know in Belgium, very excellent Palace of Justice, You see Palace of Justice?
Yes.
And Palace of Justice with never-ending maintenance, never-ending constructions, never-ending, It's so important to see when we are building European Union with never-ending stories.
So that's what the health union is about.
To propose, to introduce, to strengthen European treaties. We need to have health as an aim of the European Union, not as an ancillary issue. You know that health has three phases in the European Union. One phase is based on public health, Article 168. Second phase is based on internal market. We can use internal market regulation because of tobacco, alcohol, health data space. And third phase is fiscal one. And through fiscal one now, keeping in mind, Stability Growth Pact, we can use instruments, European semester, and press countries to do more to addressing issues about healthcare. But it is not enough. We have only a small line in Lisbon Treaty which allow us to have shared competencies, cross-border healthcare threats. And Article 168 allows us also to cooperate, supplement, and coordinate. I always was advocate, look, we need to address people's needs. You know about people's needs. It was conference on the future of Europe. Yeah. A lot of citizens tell us, look, we need to have more strongest instruments at pan-European level. Okay, then European Parliament presented motion. Yes, we need to move forward with treaty changes. Then you just quoted Ursula von der Leyen. She told for her it's crystal clear that we need to build pan-European health union. Excellent. And then she told, so finally, I am not against treaty changes. But then they pushed question to Council, and our heads of states decided to shy away, and then they are never asking people what people need from them.
So, okay, we're talking here about treaty change. That's a good question. The other politician here on this panel, do you think treaties should be changed because to make health policy even more prominent?
We certainly shouldn't hold back in the meanwhile. So we have a lot of powers available in the treaty. We have the determination to bring forward change. I think the last year and a half since the beginning of the mandate of the European Parliament, with the establishment also of a new health committee, we have done an unprecedented series of decisions, including Critical Medicines Act, already at first reading in the European Parliament. Tomorrow we're voting in the Health Committee on the pharmaceuticals package. There's a lot on the table, and we will definitely not hold back because it's not a specific shared competence in the treaty. I mean, the treaties speak about a complementary competence. It's true that we can strengthen the hand of the European Union. We can do more if there is a clear shared competence. But, citizens are asking us for results right here, right now. I mean, I agree with Vytenis. I mean, when you meet people in Malta, I come from Malta, they do not care about treaty competences. They care about their situation right here, right now. They care that there is a better cancer care, for instance, for smaller member states where it's more difficult to invest heavily in infrastructure. They care for medicines availability. We're doing a great step forward tomorrow in the Health Committee with the pharmaceuticals package, ensuring a wider availability of medicines. So we must act right now. I think we're doing a lot in very record times, like for the Critical Medicines Act.
Yeah.
A very short time since the Commission presented the Act to the time that the Parliament decided. Now it's in the negotiation with Council. So it's true, yeah.
So
we
I
can,
see
we can, we
the
can
EU
do
is
more,
doing
but we must use the tools
Yes.
that we have available, and we must use them in an optimal way.
From
for
a
results.
governmental perspective, and I'm looking at you, Sven, many governments around Europe are still a bit reluctant sometimes to transfer more health powers to Brussels. In your view, are there areas where EU action is demonstrably more effective than national action?
I think we have already a rather good starting point at this point. We have EU agencies, health agencies that have their mandate revised, and we still have some way to go to have this fully implemented. Just this year, ECDC will have all member states assessed, so they will have their homework to do, member states, I mean, and they will have to invest resources there. They will have to cooperate closer with ECDC, with HERA, maybe with EMA as well. So there is still some way to go, and we need to explore these flexibilities that we have already. And I think treaty change is a mean, but what end do we want to achieve? And then maybe we define the end that we want to achieve, and then we look at the means we need to get there. So what I'm trying to say is that treaty can be changed, we can go in that direction, but what end do we want to achieve?
But what area do you think national competence is important in the field environment? In the health environment, sorry.
I don't think that anyone would question that still national competence when it comes to purchasing, providing is still purely national competence, and I think this is out of question. When we look in the future, I think we can look at the intersection of non-communicable diseases and communicable diseases, because we always have groups that are elderly, that have multiple diseases. They are at higher risk for communicable diseases as well. They usually have worsened health outcomes, treatment outcomes. And also when we have crisis situation, that would usually hamper access to care for chronic patients. So there are those intersections, and I think we can do more in those in that direction.
Okay, I'd like also to look at also from the civil society perspective. And going back to the first question I had, I really want to see with you, and so so that you share your knowledge also of how much the EU has gained powers in this in the health field. I look at you, Milka. What would you say?
Well, I would say the COVID pandemic was a important crossroads for us. It has taught us a lot. We've been discussing it whole day long today. We have faced challenges imposed by the pandemic, but we have also taken a very important lesson, which is that health is a strategic asset for Europe. And having said that, what I mean is if health systems are in trouble, everything else collapses, the societies are suffering, everything else is suffering. So I would say that it doesn't really matter where are the different competencies levels. It matters what kind of health care delivery will be reaching the patients. But patients are not the only endpoint here. We have heard today about the importance of prevention, and I think that's one of the key points that we need to raise here and take a step back, because all the pressures that we have discussed today, medicine shortages, pressure on innovation, pressure on competitiveness, everything can be reduced by more investment into prevention. Commissioner Várhelyi was saying this morning 80% of cardiovascular diseases are preventable. Add on top of it 40% of cancers are preventable. Then imagine the amount of decreased pressure on the health systems if we would invest more in prevention. And there is data that says that for every euro invested in prevention, there is 14 euro return on investment. And I think that's the key learning point from the pandemic, and that's the probably the key point on which we need to focus also for the benefit of societies at large.
So, Matthias, you help European policymakers, health policymakers, to design health policies. In your views, based on your research, what would be the impact of greater EU health mandate?
A greater EU health mandate, from my point of view, is not needed if we want to respond to a crisis, because the historical learning is that we can do great things, if we have agreement. And this was the case in COVID-19. New budget, bigger budget, new institutions, new mandates, new policies. No need for change in the treaty. And the same is true actually for the response to the economic and financial crisis. Health and health systems became part of the macroeconomic toolbox across the union. And I could go into the BSE crisis or the blood crisis. There's the same pattern. But if we want to shape health and health system, if we want to go forward and talk about the European Health Union and see where we can help, like, for example, with the health workforce, I think then it would be good to have a better mandate. But still, we know the change of the treaty is a very cumbersome, long thing, and the outcomes are really very uncertain, because we all know nothing which goes into the parliament comes out the same way.
And it's maybe not necessary right now, as you say.
It's a long-term thing.
Since we talked about COVID-19, and I think for this panel it's clear that the lessons of COVID-19 are very important and are still important now, I would like to really try to be very concrete in this panel and really see what is the concrete change from the COVID-19 that you've seen, that the most relevant change. Maybe starting with you, Peter. What is the concrete policy that has changed?
First of all, I'd like to put on the table one thing. COVID-19 has brought a lot of suffering in our families, right? But it has touched roughly 1 out of 10% of the population. When you see diabetes, for instance, diabetes touches 12% of the population in Europe. Those who know about it, who treat it, touches up to 40%, those who don't know about it, but suffer its complications. Cancer, 1 in 3 of us will have a cancer diagnosis until we reach 70, unfortunately.
And we've seen breast cancer being generalized.
1 in 3 of us is suffering from heart disease and may die from heart disease. So those together, they are a much bigger silent pandemic than COVID ever was, even though COVID turned our society topsy-turvy. But in reality, we have bigger ongoing challenges that affect all Europeans and should be treated as such. Now, the lesson taken from COVID is that necessity is the mother of invention. So where we needed, we found the competences. And I think every minister will concord that the European Union was providential. And if you speak also to citizens, and they start criticizing the European Union, sometimes I get this backlash, when I'm with people, and I tell them, think about COVID. The European Union was there to help your family. So it is definitely a success story. It is something that shows that Europe can deliver under stress. This is something to tell about our European Union as well.
But if there was one concrete change, is it on procurement? Is it on,
definitely,
cross-border?
Procurement is the key takeaway, and I think we have replicated as much as possible the lessons drawn from COVID-19 into the Critical Medicines Act, where now we have a systemic way where the Commission had proposed 9 countries. We are proposing 6 countries can cooperate to buy medicine together. And there's another aspect to be said here. Parts of the industry were not happy with this because you have importers, producers being maybe bypassed through these joint systems. But this is what the citizens are asking for. We can buy together buy cheaper and secure the availability of medicines for our citizens. So that should be secured for the union list of medicines. So not all medicines, but the most important ones, especially for chronic diseases, right? This is something that a lesson from the COVID-19 we have now put in place as a law, which is being negotiated, but it's in an advanced stage of being, and there's a lot of overlaps between Council and Parliament, so I trust this is something we will see as law soon
So
enough.
staying on this concrete change, Mr. Andriukaitis, you have experience, so tell us a bit more what you think of what is the major change since COVID-19 that you think should be used for decades onward.
No, first of all, I can tell you main changes were that now all trying to speak about European Health Union. The name was coined because of pandemic. Was coined. Santa Maria. It was very excellent. Very excellent. A main asset. Second, you just raised questions about procurement. About my question is to all of us. Please tell me which country can treat patients with rare diseases, rare cancers, and multi-complex diseases being alone. If you are speaking about national competence, let's do Latvia. Let's do it. I 2 weeks ago was in Riga, attending meeting on rare disease conference. I told Latvian government, why you are not treating patients? It's your national competence. Why Malta? Why are you not doing? You have no chance to do it. Because you have no doctors, no capacities, no understanding, and in some areas you have a lack of capacities to deliver treatment because prices very high, because patients in different. Why we are so silent? 36 million patients now suffering at the moment, which we are calling rare diseases. They are dying. You know how many treatment do we have in Europe? Only 5%. And if you look into orphan drugs, colleagues, orphan drugs today is in collapse. From 40% in 2012 till 2022, please read Draghi report, till 5%. Europe, where you are? Wake up. Now we are discussing about Biotech Act, about Critical Medicines Act. It means that we need to raise very precise questions. Why we need shared competence? Where? Rare cancer, rare disease, rare, genetically determined disease, and of course, possibilities to join excellence centers, to build capacity, to address people on the ground, helping member states to treat your people on the ground, but not leaving those behind. That is about what we are speaking. That's the main challenge.
The issue you touched upon, which is interesting, I think, is the fragmentation in Europe when it comes to access to medicine, when it comes to a lot of things. There's a problem of fragmentation. And I want to talk to Sven maybe before. How do you think the EU can do something, and what should it do to avoid this fragmentation?
Because national competence.
Well, first thing that comes to my mind is we can strengthen joint procurement, especially when it comes to rare diseases, because we have such a small turnaround of the amount of drugs that we need for those rare diseases. The small countries, in particular, don't have the purchasing capacity. They don't have the negotiation.
When you say capacity. Your country is affected by that, you say?
Yes, definitely. We are a small country, and I think it affects more heavily small countries than larger countries, simply because we have even fewer patients and even fewer administrative tools to do that. So I think here EU can clearly do more, and I think there are tools in place, and in the future I see quite good prospects in this direction.
Milka, could you maybe respond this, because this is an important question about fragmentation. How do you think we can solve this issue?
Well, it takes us back to the question of treaties and to the question of member state competencies and the European competencies. I think the greatest learning from the COVID pandemic is that Europe can coordinate. And if you think that greatest takeaway, if you want, the greatest takeaway was the strengthening of the European Health Union, DG HERA was established, the European Medicines Agency was, the mandate of the European Medicines Agency was strengthened, the mandate of the ECDC was strengthened. So these are the core competencies of the European Union that demonstrate how well Europe can coordinate. Now, the EU doesn't need to run the national health systems, but I would also say that European coordination role is not only in crisis response, it's not only in industry policy. European Union can really uniquely support the prevention, support health equity across different member states. It can support action on the determinants of health that are cross-border, and it can do that coordination across countries. And I think that's the critical role of the European Union. What bothers me, or what concerns me, is that we're just a few years down the line from the pandemic. But the importance of health on the political agenda has really dropped down very, very quickly. And that is of concern, because then that means the investments in health and in everything that European Union could do in terms of coordination is going to drop down. So I
because of other priorities.
Exactly. And I would just say, just one sentence, we will see the next European budget as a barometer of the importance of health in the European Union. We need to see kind of a budget line for health if we are to talk about health seriously in this union.
But yes, do you share this concern?
Well, yes, to some extent. First of all, I think the European Union has really demonstrated that it has a role in supporting health systems and health system development in countries. And I think this is not going away, because there are instruments and budgets, and I think they will be rather rationalized and improved and embedded, because countries are accepting this. And this is a big change, actually. This said, there are a lot of uncertainties around the future of the budgets and the health budget. We're not quite sure about this, and it's a bit like gazing into the crystal ball at the moment. But we, of course, want to share the very positive results. You know, health has been on the top of the agenda during COVID-19. You know, countries saw it plainly. It has a role in health systems, the European Union, despite the discussions on the mandate. And very positive experience were made. I think that the European Union has demonstrated that it can really act and make a difference. So I think there are a couple of lessons learned from this, and I hope a positive kind of attention is coming out of it.
I'd like to focus a little bit on something that you mentioned, which is, sorry, the medicine shortage, because we know this is a huge problem here in the EU, because, you know, Europe is facing recurring shortages of medicine and medical supplies. We see it in the news very often. Is this something that member states can solve individually? Peter, I'm looking at you.
Absolutely not. I mean, if you look at, for instance, the last weight report by the pharmaceutical associations, right? You see a picture there, a frightening picture. It takes, I think it was mentioned in some of the panels before, it takes 300 days for an innovative medicine to be available in some countries like Germany and France, but it takes 900 to 1,000 days for a new medicine to be available in Malta, Estonia, Latvia, and some other of these countries. So countries on their own are, especially if it's a small market, you have very limited bargaining power with the giants of the pharmaceutical industry. And this is why the European Union, the European model, has to work in these areas. Now, we have already several pieces of legislation which should be doing parts of this, but we need to fine-tune, we need to tweak a lot of these legislation to make sure that they deliver better. When it comes to availability of medicines, for instance, the pharmaceutical package now have a number of, it's like button and the stick approach, you know. I incentivize the industry to deliver and to make products available in all of the market. At the same time, you know, I can use the button approach if they are not delivering or if they are not sharing their products across Europe. So I think we must do much more in this area, because the disparities are huge. Even if you look at the availability of medicines when it comes to reimbursements. If you see the reports, it's 100% in Germany and Estonia for a lot of medicines, for instance, for cancer. And it's up around 16% or 20% in many member states like Malta, for instance. So there's cause for a lot of more work when it comes to, I think Milka mentioned health equity. You know, we are a union of people, which finally in the treaty, when we speak about competences, okay, we have complementary competence when it comes to health, but we have also cohesion policy. Cohesion policy obliges us to push forward our regions together to achieve similar levels of prosperity. And how can you have prosperity if you have a lot of patients in your member states, you know, not having access to certain levels of cure or medicine where they are in the same European Union? So there is cause for doing much more, and I attach this also with competitiveness in general for the industry. We care for the industry. We want the industry to prosper, to get stronger in Europe, to base itself in Europe as well. Let's say it.
Well, we'll talk about innovation, but I want to hear about
the more they provide, even for the lesser, for the smaller member states.
But when it comes
the more
to
competitive
shortages,
they become.
Mr. Andreokaitis, how can the EU solve this issue?
Mind the gap. Yes,
mind the gap.
You have a greater health mandate. And look, European EU for Health program. In the beginning was separate one. It was joy. You know, they put 5 billion euros in EU for Health. Finally, they cut 1 billion. Now in UMFF, what have they proposed? Separate, standalone EU for Health disappeared. Yeah. Welcome to greatest mandate. What are you doing? Where is EU for Health? Or cutting grants to civil society? Where it is? It is put it into competitiveness fund. And competitiveness, what does it mean? Industrial part, or addressing shortages. Who will be keen address shortages? Ministers of Health, because their headache, you know, how they can compensate, what they can do. Our industry is not care about. But we are putting money into competitiveness fund. It is in front of MFF. It is front in knowing how and big challenges are in front of us related to people's health. Crucial challenges. Inequality, second-hand patients. I can't speak, you know, without emotions, because it touches my heart. And now we are speaking about greater health mandate. It would be good to see to smallest countries, let's join, otherwise we can always face shortages, always.
But you have a government official next to you. Maybe he can respond to that, since you're talking about governments also. Does it mean, you know, governments should put more money? The EU should put more money, should fund more health?
Unfortunately, there is no one-size solution to all of the problems for the shortages. It really depends, sorry, what is the root cause of the shortage. If we, I will give you one example. We had a week or two before, just as you mentioned, headache of the Ministry of Health. We had a shortage of oxytocin, a very demanded medicine for labor, and we only had 2 marketing authorization holders in Latvia, and one went out of the, there was manufacturing problem. And the other one didn't have their product on market, so we had to find a solution. It is not a problem where you don't have a manufacturing authorization holder who's waiting for being in the reimbursement list. Rather, it is a problem that our market is so small that we don't have more than 1 or 2 in our market present. And if something happens, then it is very likely that we would be affected by that problem, by in that situation. When it comes to manufacturers not willing to place the product on the market simply because, again, it is too small, but it has not been on the market before, we hope that the new regulation will help with this situation, and it will encourage more manufacturing holders to place their products on the market. Yes, finally, we do agree that the EU can do more also in long-term shortage mitigation. We can differentiate active pharmaceutical ingredient sourcing places, not just in Asia, but preferably also somewhere closer. Final product manufacturing sites can also be more in Europe. We can do more to encourage manufacturing in Europe, and that will help us in the long term.
Okay, Milka, maybe, and Matthias, from the civil society perspective, this medicine shortage, you talked about prevention. How do we solve this issue?
For me, well, first of all, shortage is not the core issue. Medicine shortages are not the core issues themselves. They are symptoms of a deeper issue. And no single country, and Vytenis is right, no single country can sort this out alone, especially small countries. Like, it's an issue that has to be treated handled, tackled by the European Union. And that also leads me to the point that we need to see health as a strategic infrastructure for the European Union and for the member states. And that brings us to what Vytenis was talking about, and that is the dedicated EU for Health program within the new MFF, the multi-annual funding program. So the civil society has asked very clearly, demanded very clearly, a clear health line in the upcoming new long-term European budget. We have also specifically asked for investment in prevention and public health, because that reduces pressure on the health systems. And by that I mean disease prevention, health promotion, and tackling the determinants of health, because that is under European competency. Of course, also stronger preparedness. Yes, there is DG HERA, but we need more investment in health security. We need more investment in EU agencies, in cross-border cooperation. And thank you, Vytenis, for bringing this up. We really need support for civil society and public health expertise. We need funding mechanisms that will allow European civil society or NGOs and public health networks to contribute to European policy making, because otherwise the democratic policy making is at stake.
Matthias, do you share also this assessment?
Yes, absolutely. And I would like to say that, again, the COVID-19 responses are very important because we purchased together the vaccine. If not, smaller countries, less affluent countries, they would have needed to go to the back of the line, and they probably wait for very long and would have suffered quite a lot. This said, it's not only about pharmaceuticals. We also need to see that we are talking about medical education. If your country is very small, you cannot train all medical specialties. It's also about specific procedures, devices, high-tech devices. Not every country can have them in stock. You know, we need to share. This said, not everything does need European legislation. You know, we can have coalitions of the willing, you know, countries that work together on a voluntary basis, actually, but we should facilitate this and we should learn from each other, and maybe the European Commission could here have a role in coordinating this and encouraging.
But what we haven't talked about really is our dependency also on other countries and turning to Asia. You know, the shortages of medicine also are linked to that. So, Vytenis, I look at you. How do we stop this dependency that we have from the Asian market, for instance?
Frankly speaking, I am just smiling because don't blame Commission. Don't see the Commission to coordinate. The main issues, you just mentioned the question about fragmentation, because it's related to shortages too. What does it mean, fragmentation? National competences. You have no one single market, colleagues. Till now we are not completed. Now let us propose very excellent sentence. You know, excellent sentence for letter report. One Europe, one health, and one market. It's simple, but it is absolutely understandable, colleagues. It means that we need to see how can we really achieve. Of course, we can achieve it using secondary legislation. As now we just raised a question about Biotech Act. Critical Medicines Act, Biotech Act is ongoing. I am rapporteur on Biotech Act. Now we have I finished meeting with DG Santé discussing how can we move forward. Biotech Act can help us also to extend situation and to build pan-European ecosystem for research, investment, innovations, and of course, keeping in mind that we can address needs of member states on the ground. It's not about keep powers in Brussels. No, it's a mistake. We need to solve problems in Malta, in Latvia, in Lithuania, in your country. It doesn't matter. But we need to have one European ecosystem can allow us to more faster, more attractive, more competitive, inviting our medicine, matter businesses, come back to Europe. 40% of orphan drugs, now you have 5 biosimilars from thousands going down to hundreds. What is and
going back to the initial question I had, and I'm looking at you, Peter, is there was a report from the European Court of Auditors warning Europe faces persistent shortages of essential medicines, including antibiotics and painkillers, partly due to this reliance I mentioned on manufacturing in Asia. So how do we stop this excessive dependency we have towards Asia?
We're speaking a lot about European sovereignty these days, and this is part of the equation, of course. We must, on the one hand, promote industry production in Europe and servicing in Europe, at the same time promoting also innovation in Europe, because this is at the root of the problem. Because if companies cannot invest here and innovate here, they will not test products here, they will not put them on the market here. This is one of the factors in the Biotech Act, for instance, when it comes to clinical trials. But at the heart of it, I mean, we mentioned also budget, and definitely money is important.
Yes.
So the fact that the European Commission is not proposing a specific budget for health is concerning. I share Vitenis' point here, I think is echoed across the board. But it's not only about money. And I want to make the point here. I know there are thousands of millions, if not millions of viewers watching us right now on Euronews, okay? You need to ask for your rights. For instance, we have a European cross-border health directive. You know, I meet a lot of people, for instance, in Malta, telling me, Peter, I have this problem. I mean, what do I do? This care is not available in Malta. What do I do? There is the European cross-border health directive, which gives every citizen the right to access care which is not available in his or her country. Ask for your rights. Push your politicians, push your authorities to make good use of what we already have on the table. Because when we use what we have already on the table and we test its limits, then we realize what we need to do next. And contact your politicians, ask a lot out of them, and we will try to keep up with your demands.
This debate, we're running out of time, and this debate needs to end, but I thank each of you for participating. I feel like one of the takeaways is really that the funding for health needs to be improved, needs to be enhanced. And thank you so much for all of your contributions, and thank you to all of those who are online. Thank you very much. Bye-bye.
Thank you.
Thank you so much to all of our speakers there, and to Maya de la Bom, our correspondent, for moderating that panel. Now, as our guests leave the stage and as we have a very swift furniture change here on the stage, just a moment to remind you that if you are interested in Euronews' health coverage, we do have a team of journalists dedicated to health, so do remember to follow their work on Euronews. But now it is time to move on to our very final item of the day, and I'm delighted to say that we're joined by the Czech Health Minister, Adam Vojtěch. He will be interviewed by our Euronews' health journalist, Marta Iraola. So I'd like to welcome them to the stage. Thank you.
Hello, thank you. Good afternoon, Minister. Thank you for being here. It's a pleasure having you in our Health Summit.
Well, it's a pleasure for myself to be here with you. Thank you.
Perfect. Well, Minister, your government has made health a clear priority. Prime Minister Babiš himself has said that there's no cutting corners when it comes to people's health. In a Europe that is mostly focused on defense and economic discourses, how do you explain this focus?
It's true. I heard a panel before, and the panelist mentioned that health is not the priority number one anymore after COVID pandemic. For our government, it's not the case. You know, the Prime Minister and myself, as a Minister of Health, our whole government repeatedly declared that health is priority number one, because we strongly believe that without healthy population, we cannot, you know, build the resilience of the society. You know, we're talking about defense, security, but in my opinion, it is connected with resilient society. And for the resilient society, you need a healthy population. So that's why, and so it's both like physical health, but especially mental health. And what we see now, like how mental health is getting worse within the society, especially among the young generation, it's very concerning. So I think the national governments, but also the EU, should definitely tackle this thing as well.
Well, you talk now about mental health. You started your mandate, you took office in December 2025, so just a few months ago. What do you see as the main priority for Czech healthcare right now?
Yeah. Actually, I'm a Minister of Health for the second time, because I was Minister before, also during COVID pandemic, unfortunately. So I kind of continue with some reforms I already started before. One of them is mental health reform. We started in 2018, also thanks to EU funding. We continue with this reform because the situation is not improving much. So we need to, you know, build up all the services that are needed. Community-based services and so on. So this is one of the priorities. Then digitalization. We have the European Health Data Space, so we are implementing, and for us it's very important to digitalize all the system, you know, all the documentation. When I was minister in 2018, I started electronic prescription, which is now working very well, but we need to move on and digitalize all the documentation and share the data and work with the data. You know, I would like to base the health system on the data-driven decision making, which is very important. And I strongly support also EHDS that may help us also to share the data within the EU and also use the data for the secondary purpose. So digitalization is another priority. And then long-term sustainability. We are facing aging of population as in other countries, and in the Czech Republic in the upcoming 10-15 years, the number of people above 80-85 years is going to really jump up significantly. So we need to prepare the system. We need to strengthen the long-term care, home care, you know, and this is what I'm focused on. And then, last but not least, prevention and primary care, the role of GPs in the system and promoting prevention, because, you know, I strongly believe that prevention is the key to sustainability of the system. We face the burden of chronic diseases, not only mental health, but cardiovascular diseases, cancer, and so on. So prevention is the key.
You mentioned prevention and an aging population. We're seeing also, linked to both these things, rising in non-communicable diseases, such as cardiovascular disease, cancer. It's affecting all countries in Europe and the Czech Republic. How do you see a shift from the system, from these systems that are mostly based in treatment to systems that are focusing on prevention?
Yeah, some experts talk about medicine 3.2, 3.0, that is like based on prevention, and I strongly believe that it's true, because, you know, like we cannot only like cure patients, although we need to offer the best available treatment, you know, like innovative drugs, innovative healthcare. But on the other hand, like if we do not support prevention, the system won't be sustainable. We see, especially in the Czech Republic, but I guess anywhere else, like how the circular diseases, you know, the cardiovascular diseases are still the cause of death number one. Cancer is growing. Neurodegenerative diseases are also like a kind of concern for us, Alzheimer's disease and so on. So we see all these issues, and without the prevention, without promoting the prevention, prevention, we cannot sustain the future of our health system. So that's why we are focused on that primary prevention. It means like reducing obesity, promoting physical activity of children, especially. We want to work with schools, and then of course decreasing the amount of smokers and alcohol consumers. This is the problem, especially in our country. We have always been in or three top countries in terms of alcohol consumption, so we need to tackle this. But then the secondary prevention, it means early detection, screening programs and so on.
And well, Minister, as we've mentioned, we live in a world full of growing health threats. We've heard today about pandemics, antimicrobial resistance, shortages of medicines, impacts of climate change. Europe is rebuilding its defense architecture, but some would also argue that global health preparedness is just as important and other topics. Is health security getting the political attention it deserves?
No, this is what I mentioned in the beginning, that really for me, health and security are really connected. Without a healthy population, without drugs that we have for our patients, for example, we are not able to survive. So, for example, this Critical Medicines Act is something I really hope will help us to make the system or the pharmaceutical industry or availability of drugs more stronger and more self-sufficient. Europe in this term, that we would not depend so much on third countries. This is the experience we have from COVID pandemics as well. I personally remember it very well, especially in the beginning, how we had to import, personal protective equipment from countries like China and so on. And it's the same with pharmaceuticals. Look at the production. It was mentioned also before in the panel that currently the APIs, the active pharmaceutical ingredients, but also the whole production of drugs is based a lot in third countries, and we depend on them. So I think Europe should do more. We should strengthen our domestic production in terms of medicines, and hopefully this new legislation will help. On the other hand, and I'm critical to some steps of the Commission and European Union, for example, in terms of urban wastewater treatment directive. That is, in my opinion, undermining the industry, because it puts burden of the cost of wastewater treatment on the pharmaceutical industry.
Thank you so much, Minister. This is all we have time today.
Thank you.
It was a very insightful conversation. Thank you so much for joining us.
Thank you for the invitation.
It was a pleasure.
Thank you. Thank you.
And to Marta as well, thank you so much. But that brings Euronews' Health Summit to an end. We've had a very vibrant debate. We've heard about the challenges, but also the opportunities. Thank you to our viewers at home, everyone here, and to our partner, Sobi. There will be refreshments for you here, so do stay with us. But thank you for joining us, and we'll see you very soon here on Euronews.